the
Check,
pointer,
check.
is it over there?
Check. Check, check, check. Check, 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 check. 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 Check, 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 check. Check, check, check.
Oh, no?
Check,
Is that the
check,
pointer?
check. Check, 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 check.
Okay. Yeah, yeah. It's working. Okay. Yeah, yeah, of course.
Check, 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 check. Check, check. Check, check. Check, check, check.
Check, check, check.
Check, check, check. Check. Check, check. Check, check.
Om Swastiastu, Assalamualaikum warahmatullahi wabarakatuh, Shalom, Nama Budaya, greetings of welfare, peace be upon us all. Ladies and gentlemen, welcome to today's guest lecture, Frontiers in Anesthesia, New Induction Agents, Airway Interventions, and Ultrasound-guided Regional Techniques. It is an honor to stand before you as we gather for this momentous scientific event. First and foremost, let us express our praise and gratitude to the presence of Ida Sang Hyang Widiwasa, the Almighty God, for it is by His grace that we are able to come together today. Allow me to introduce myself. I'm Giselle, and I will have the privilege to guiding proceedings this morning. Before we commence, I would like to extend a warm greeting to our esteemed teachers and to all the invited guests who have joined us. Today, we are going to hear in-depth discussion for our guest lecturer, our visiting expert, Professor Dr. André van Zundert, MD, PhD, FRCA, EDRA, FANZCA, to share his expertise with us today. Welcome to Bali, Prof. André. I believe it is not your first time here, and we hope you to enjoy your time here. Please join me in giving a heartfelt round of applause for welcoming Prof. André.
Thank you very much. Can you hear me? Okay. Selamat datang. That's the only words I know in Bahasa. I'm very sorry. It's not the first time I'm coming here. I think it's already 20 times that I'm coming here. So it's an annual event for me, and I'm always very pleased to be here because I see you as my friends. Yeah, it's and thank you for the introduction. It's always a pleasure being here. I like Indonesia. I like coming to Bali, although I'm only here for a short time. But it's always to see all these nice people, and they are willing to learn a little bit from my knowledge. That's my drive. I'm not like a boss. I'm not like a commander. I'm like an architect who wants to inspire people. And I want to be, yeah, it's like my PhD people. The PhD doctorates, and I've supervised already more than 50 of them, 50. So, and 11 of them became a full professor in their own rights. So that is my legacy. You understand? I'm like a soldier who knows how to service. Yeah. I want to inspire, I want to give you all kinds of opportunities to work, to collaborate, and to take home some of my messages. That's what I want to do today. Is that okay? Good. Shall we start with the first lecture, or do you want to do something else?
Can we take a photo first? So
Oh.
please, the Prof, be seated in front.
Yeah?
And please, Dr. Aryawangsa and Dr. Prema, please join us.
Yeah.
And we are taking the photo. Please, all participants and our speaker, our teachers, stand.
I need to stand up?
Yes, stand up, please.
Okay. Here? Okay.
And on my count, please smile. Look at the camera on 1, 2, 3, smile. And 1, 2, 3, smile. Thank you. And
Thank
we
you.
commemorate the opening of this first lecture. Please give us your insight.
Thank you very much. Also welcome those who are attending via Zoom or whatever means you have nowadays, okay? So I'm going to give 5 lectures today. And the first one is about, improving anesthesia recovery through patient-tailored biological neurocomputation in artificial brains. Very difficult topic, yeah, but I will explain you later, okay? This is the next one. Okay. We are providing anesthesia, which is a blessing. It was in 1846 in Boston, Massachusetts, United States, when they gave the first presentation, and the first anesthetic was given on Mr. Abbott, a young chap with a tumor here, and they took it out, and for the very first time they could do that without causing any pain to the patient. You understand? So it's very important. This was the event of the year. It was like going to the moon. Yeah, an enormous impact on society. For the very first time, no pain whatsoever during an operation. And that was a true blessing. But for anesthesias, the anesthesiologists did not understand how really does it work. We had that fantastic product, ether in those days, later chloroform and all the other products, but do you really understand how it works? And that's the thing that I'm going to talk about today. Oops. It's like that. So how do these anesthetics work? I was always interested in, for instance, sedation, anesthesia, and you can even see it in the animal world, in the human world. And I did one of my PhD thesis. You see, I was the promoter, at the University of Ghent, and that was on the first sevoflurane pharmacokinetics. So that was my student, and I did that in those days. So the mechanism of action of general anesthetics, that's what I'm going to try to explain to you, how it really works. And as you can see, sometimes we have these patients in the post-operative phase. You're not recovering completely. We have post-operative delirium, post-operative cognitive decline, especially if there's pre-dementia, for instance, pre-existing dementia. Now, what can we do about that? These are vulnerable patients, frail elderly patients, with pre-existing neurological. How can we do a better job? How can we make sure that our patients in the post-operative period are not experiencing these kind of things? This is the brain. This is our brain, and as you can see, we have lots of connections here. Lots of axon, dendrites, cell body, and this is one of them. You see, this is a cell body, an axon, and dendrites. And how many do we have? You can see it here, 100 billions of these neurons. So this is one neuron. And in our brain, we have about 100 billion of these neurons. So it's very crowded in here. Another support cells, 100 billion glia cells. So we have 200 billion cells here, support cells, the glia cells, and the neural cells. Okay? And they make connections. You see, they make connections everywhere. You know how many connections? Well, 100 trillion. 100 trillion connections. Now a trillion is a 1 with 12 nils. It's far too difficult for me to express it, but you do understand that's what is happening. Okay? Now, we have one neuron talking to the next neuron. We call that brain talk. You understand? This is a very important slide because I'm going to use it all the time. So, one neuron is talking to the next neuron, bringing information from here to the next one. Okay? And that results in 3 different actions. First of all, we have our motor skills. We can move, talk. You see all these kind of skills, motor talks. The next thing is that we can hear, we can see, we can talk, we can smell, all the senses. Okay? So motor skills, all the senses, and then we have all the organs. Okay? So 3 things. And they all depend on that information transmission from one neuron to another neuron. That is the basic thing. If that doesn't work, this does not work. You understand? So it's very important to understand this mechanism. Because I'm going to focus more on this one. Okay? I'm doing something wrong or what? Hello, good to see you, good to see you, good to see you, good to see you. Okay. Okay, it's working now. Okay, so I'm going to talk about the neuron transmission. And that is going to give information. Okay? Now, the Nobel Prize was given to this person, and that's in Oslo, Norway. Yeah? And as you can see, he got a Nobel Prize for neurotransmission relief, Professor Thomas Suthoff. And what he did, he checked the calcium transmission. Now, this is the neuron transmission, and we have calcium here. And calcium seems to be a very important aspect in that transmission from information from here to there. You understand? So he got the Nobel Prize, and you can see there's a lot of going on between one neuron and another neuron. One neuron and another neuron. You understand? So that mechanism whereby information is transported from this to the next one, you need that calcium. You also need sodium, potassium, and other electrolytes. But the calcium one is also very important. Okay? That is what is happening. Sir John Eccles got a Nobel Prize in 1963 for another mechanism, and that mechanism is the GABA receptor. We all know the GABA receptor in the postsynaptic membrane is an important aspect of anesthesia. Understand? So 2 people already got the Nobel Prize. You see, this is the GABA receptor, and this is, for instance, an anesthetic. You see that? That's an anesthetic. I'm not going to go into detail, but it's an anesthetic like, for instance, etomidate or propofol. Okay? So, he got, the one person got it from the calcium, and he got it from this mechanism, the postsynaptic mechanism here. So the GABA aminobenzoic acid, he discovered that, as an anesthetic target. Anesthesia is not going to work in one particular place, maybe 20 different places, one more important than another. So that is what we are doing, okay? Now, in the human brain, I got this image, but in fact it's not 86 billion, but 100 billion. So the figures are not 100% correct, but I found this overview just to show you. There's only one animal, the elephant, who got 250 billion neurons. That's the only one in the animal kingdom. So an elephant is a very clever animal, you understand? But if we look at, for instance, Drosophila flies, fruit flies, or we look at a roundworm, you see this one here, the roundworm, they have 300 neurons. That makes it much easier for us to study the mechanism. You understand? If you have 100 billion cells in here, how to study that? But if I only have 300 neurons, then I can study it much easier. That is why we are using, in our institution, these kind of animals to do studies. Okay? Again, don't forget this one because that's very important. Now, we know the neuron to neuron talk, that's brain talk, and the process by which signals are passed from one neuron to another neuron, that is what we call that neuron talk. But how does it work? We have the calcium already, we have the postsynaptic membrane, but we were focusing on the presynaptic. This whole mechanism, nobody was looking at it. The presynaptic transmission of all this information, you see all this information that needs to be released into the synapse, and then it goes to the GABA receptor. Okay? So what we were doing in our institution, studying this mechanism from the formation onwards till it's in these vesicles, and these vesicles, they move towards the presynaptic membrane, they merge, they open, they release their enzymes, you release their enzymes, the transmitter, and they go to those postsynaptic receptors. That is the mechanism we studied. That is the revolution, in fact. Okay? So, these are electrical stimuli. We have mechanical stimuli. Yeah? Chemical stimuli, the neurotransmitters. These are all neurotransmitters in here. And we need ions like calcium, sodium, potassium, etc. And then we have the receptors, which is very important. So that presynaptic transmitter release machinery, this one here, is an essential part. The importance of calcium is important, the postsynaptic receptors, and then the axon. What is it? It's a touch screen, so I can touch it. Oh, my goodness. Okay, so the motor skills, the senses, and the organs. You understand? So that brain talk is very important. But how does it really work? Okay, I'm going now to explain this mechanism more in detail. And you see we have some colors here. These are all kinds of proteins, and the proteins are listed in here. So this is a vesicle, so one vesicle here. This is a vesicle, and information needs to come to that vesicle. Information needs to come to that vesicle to attract it and bring it down here. You understand? Because it's all over the place, but it needs to be attracted, and it sits here, it should merge, and then it should open and release the transmitter. You understand? That is the mechanism. But how does that work? We have these kind of proteins. And you see this one here, we call it syntaxin. Syntaxin is a big protein with sticky fingers. See the sticky fingers here. Sticky fingers that's going to attach to the wall of these vesicles. They stick it and they pull it. You understand? Sticky fingers. So these are sticky fingers, but of course it's going to attract everything, maybe even mitochondria. That's not what we want to have. So there's a chaperone. The chaperone, we call that monk, 18, that sits on top of that. You understand? To protect it so that's not attacking all kind of substances. Okay? That needs to be brought with other proteins towards the system so that it actually can pull it down. You see, the red one here sits in the postsynaptic membrane, in the presynaptic membrane. You see that here? Okay? So it sticks over there, and then at a certain point, there's a connection to pull it towards that presynaptic membrane. Okay? When that is done, it opens and it releases the substance, the transmitter, the enzymes. You understand? So it's a very complicated mechanism. We found that doing experiments on Drosophila flies, roundworms, and that kind of thing. Okay, so now that presynaptic transmitter release machinery, this thing here, the presynaptic transmitter release machinery, that is an essential part in the neuron to neuron talk, the transmission communication. Absolutely vital. If there's one single thing that is not working, you will not survive. You understand? Many things can go wrong here, but if this is not working 100%, you will not be born. You understand? There's no chance to survive this. Okay? It has stood the test of time. It's a very precise and delicate, efficient communication system. If it doesn't work, you will not survive. Okay? This presynaptic machinery is identical in all species, from fish, reptiles, amphibia, birds, animals, human beings. It's identical. It has not changed anything at all. Okay? So all these things have the same release machinery. That's good, because then we can study it as well. Okay? That's important. The difference in brain size. Remember the elephant with 250 billion cells, the human being with 100 billion cells, or the Drosophila fly with 100,000, and the roundworm with 300 neurons. That doesn't matter. The machinery is exactly the same. Okay? It's vital importance of the mitochondria. Mitochondria are the energy, and they deliver the energy to do all these processes. This is a very intense process. It needs a lot of energy, and that is delivered by the mitochondria. I will come to that in a moment as well. It takes place, all these things that takes place in milliseconds. It's going very fast, okay? Milliseconds. And degeneration in later life, this mechanism may suffer a little bit. And I think that can be the cause for Alzheimer, Parkinson, dementia, cognitive decline, and the postoperative delirium and postoperative cognitive decline. You understand? The mechanism is very important, but there's some exhausting effect during anesthesia, so that cognitive problems may occur in the postoperative period. And you know, all kinds of elderly people, when they undergo surgery and anesthesia, often they say, I can't remember that much. We all know these kind of patients. Memory loss for a certain period of time. Thus far, we have no remedy. There's no cure. We can't help at this particular. But it's the target mechanism for general anesthetic, but also for reversal agents. Yeah? And most mutations, if there's a mutation in this area, it's lethal. You will not survive it. If there's a mutation, I will come to that in a moment. Yeah, we can have mutations here, we can have mutations here. Well, the patient will suffer. Now, this is one of our publications last year, as you can see here. So that mechanism where it's pulled down, you see that? It's anchored here in the presynaptic membrane, while other proteins are anchored into the membrane of the vesicle, and that brings them together. Okay, so that mechanism brings them together, zippering, opening, and then release. You can read that in anesthesia, analgesia. Okay? Now, what happens if that mechanism is not working well on the motor skills, on the senses, and on the organs? What will happen? Suppose the energy delivery machine, the mitochondria, are not working optimal. Yeah? You see, it's the powerhouse of the cell. It helps you with the respiration, etc., producing energy. Energy to make sure that this is going to happen. Now, this is the Lee syndrome. Lee syndrome caused by a mutation in those mitochondria. So it's a mutation defect, and it causes the mitochondria not to work optimal. And look at what will happen. This, and remember the three things: motor skills, senses, and organs. This is what is happening. You will see a little boy, yeah, who is totally unhappy. All the time he is crying like this. This is what is happening. And you see all the time seizures, daily seizures. You see movement problems, ophthalmic problems, retinopathia, optic problems, hearing problems, vomiting, constipation, hepatic and renal problems, etc. So all senses, all organs, and all motor function. He cannot move. He sits in a wheelchair. You could see that in here. He sits in a wheelchair. Okay? They can't move at all. And they will die very early in age due to respiratory failure and cardiac dysfunction. So this is one. So the Lee syndrome. You understand? Another syndrome is the Ohtahara syndrome. It's a very rare form of epilepsy due to the MUNC18 mutation. I will go back a little bit so that you are sure that you can understand it. We have the syntaxin, the important protein, but it's covered up with that MUNC. Yeah? The MUNC is the only one which is not really essential. If there's a mutation in this one here, it sits on top of that. Yeah, if there's a mutation, then we see the Ohtahara syndrome. That's like this one. You see, again, the three impacts. He sits in a wheelchair, no motor activities, no senses. He can't talk, he can't hear, he can't speak. Yeah, you see completely absence. That's his mother. She lives 25 kilometers north of where I'm living in Brisbane. Yeah, and that's a pity, yeah, because these patients, they can't move, no motor skills, they don't have their senses, they can't hear, they can't speak, they can't see anything of that. And furthermore, all the organs depend on that. That means he has seizures, hundreds of seizures every day. Must be a horrible situation for their parents. You understand? So that is what's happening just with the MUNC mutation. Just one protein, and you can't cure it. So it is very important to understand this mechanism. Now, what is anesthesia doing? Anesthesia is going to sit in between those two. So this sits on top of that, and anesthesia sits in between. Okay? So it paralyzes this transport. It paralyzes the transport so that there's no vesicle attached to the membrane, and there's no information from one neuron to another neuron. You understand the mechanism? So it's very important to understand that. Okay? Now, in that Ohtahara syndrome, that doesn't work, this doesn't work, and it affects a lot of the organs. Okay, so I'm the overall supervisor of this institution. It's the University of Queensland Brain Institute. And this is Professor van Zundert, and he does a lot of these experiments on Drosophila flies, on roundworms, and on smaller animals. And I have a whole team, as you can see here. So Professor van Zundert, Professor Wolvertang, etc. All kinds of people who are helping us to understand this mechanism. So about 250 scientists are working in the Queensland Brain Institute. And we can work with zebrafish, the roundworm, the fruit fly, you see the rodents, and experiments are very easy. You have a bowl with a fish, and if you do a little bit of local anesthetics, the fish will fall on the side. That is what's happening, okay? This is with a local anesthetic. You can do that also with general anesthetic. You can do that with sevoflurane. You can do that with propofol. You name it, okay? It happens. And if you dilute it again, you pour water, the fish will start swimming again, okay? This is a very simple experiment that can be done. This is the roundworm. Remember, we had only 300 of these neurons. So if we do experiments on the roundworm, that is easier for us to find out, to do the microscopic recordings, etc. You see, this is a Petri dish with the C. elegans, and we can look at the movements, we can record them, we can measure them, etc. You do that under a microscope. Or we are using the fruit fly. They have a few 100,000 of these neurons, but we have mechanisms, we have special, very expensive spectrophotometers, microscope, but really to the high end. They cost millions of dollars. That's a very expensive thing, but we can look into the brain of the Drosophila fly. It requires a little bit of expertise, of course, but we can look directly into the brains of the Drosophila flies. You see that experiment here? This is a ball. The fly sits on top of the ball, and every movement that she makes, we can make a recording out of it. So we know exactly what she is doing, and this is with that special microscope, electron microscope, so we can look into the brain of the Drosophila fly. And how do we do that? Okay, we look at the syntaxin, and we are using coral stone. Perhaps you know the barrier reef on the east side, northeast side of Australia. You have the barrier reef, 2,000 kilometers of coral stone. Now, one of these coral stones helps us to illuminate, for instance, the syntaxin. So we actually can make photos out of this. So we tag the syntaxin with this coral, so that it gives a fluorophore derived from the stony coral. So you can measure it. Okay? That's what we are doing. This is a setup. You see, for instance, rat PC12 cells. Or here you see the fly cholinergic neuron. Okay? So that's what I'm doing here. But these are animal experiments. Now, if we are going to make a new medication, you always want to try out on human beings. But that's very difficult with a very new concept, because these are really new medications that we developed, which did not exist at all. That's a completely new category of medication. And what we are doing right now, we are using brain organoids. brain organoids, and this is one of our PhD students here. Yep, there it is. And what you do to produce organoids? We take some blood, okay? We take some blood, we centrifuge it, and the Buffy code, yeah, white blood cells, platelets, etc. We can modify it as such that we can produce stem cells out of it, and out of these stem cells we can produce whatever cells we want. You understand? So out of blood we produce with a rather delicate program, we produce stem cells, and out of these stem cells we can make blood, we can make bone, we can make fat, muscle, sex cells, immune cells, epithelial cells, but also nerve cells. Now we are very close. This whole mechanism helps us to produce nervous system cells. You see? And in fact we can reproduce. This is like a brain with two optic nerves, optic discs that even get information from light. You understand? So that is what we are doing. We are producing mini brains that allows us to do studies on human beings, human neural cells, without having the human being, how do you say that, without using a new drug on the human being itself. Okay? So that is, you see that in a Petri disc. These are 1 to 2 millimeters in size, but they contain already millions of neurons. 1 to 2 millimeters, but they contain millions of neurons. Okay, that is what we are doing. And this is, for instance, the timeline of one of my PhD students. Yeah, you see, he has to do that in all kind of tests. I'm not going too deep into that. But what is interesting, we are using Propofol. Propofol is a universal sedation agent we are using a lot. Yeah? But if you look very carefully, it's a very symmetrical phenol type thing. Yeah? This is phenol with an hydroxyl group, OH group. Okay? Now, we replace that hydroxyl group with a fluor. And we got a whole new drug. If we inject that into these animals and use it on the brain organoids, then we'll see that it stops the working activation of propofol, sevoflurane, isoflurane, whatever anesthetic. Yeah? So this is what we discovered. But you can also see, if you put that in, for instance, the para position or the meta position, you have analogues of propofol. And these analogues of propofol have all the disadvantages of propofol, but they don't put you asleep. Okay? So they don't put you asleep. Although, I must say, in one of our first experiments, when we were using one of these, yeah, all the animals were killed immediately. That's not the purpose, of course. Yeah, we should not kill anybody. You understand? So we have analogues, and we have the propofol, the propofluor, instead of all hydroxyl. You understand? What are they doing? Okay, so propofluor, propofol with the fluor on it. So that's a reversal agent, and you can see that in this experiment, for instance, if you give propofol to the fish, yeah, immediately it will not swim anymore. It will stop swimming, it will fall on the side, etc. But if we give that propofluor, the reversal agent, you see, depending on the concentration, the zebrafish will immediately be awake again. It will start swimming again. So that is proving the effectiveness of our reversal agent. You understand? It depends a bit on the concentration. The higher concentration, the faster the animal will be awaken. Okay, so we are absolutely sure Propofol works on several places into the brain. Yeah, in the postsynaptic membrane, the GABA receptor, yeah, in the presynaptic membrane, it's here, and it also works on kinesin. I'm not going into detail because it's otherwise too complex. But we see that propofluor, yeah, is working on that presynaptic membrane as well. So neurotransmission, propofluor reverses the propofol-induced impairment of neurotransmitters. It just kicks it out. Remember the syntaxin and that Monk 18 chaperone drug on top of the sticky fingers? It sits in between, and if we give that propofluor, yeah, it kicks it out of that position. That is what is happening to do. So control activities, you see with propofol, it decreases the activity at least with half, and with propofluor, you will see it regains it back. I have a lot of PhD students. I told you I'm the supervisor of more than 50 PhD students in the past. Actually, I have 6 of them. You see a new names of them. Okay, and we have a lot of expertise. You see all these professors. We are looking at the rodent neural, human cortical organoids, patient-derived neurons, and finally it's my hope that we can use it into the clinic as well. Yeah? That it is no longer just a product that we are testing, yeah, in our labs, but that we can use it into the clinic. Okay, so a whole group of people are working on that. So the search for general anesthetic reversal agent, it was a long time dream of me, and we are looking at behavior, but also more, yeah, in detail, like single molecule dynamics. And we published a number of these articles on the topic. This is in anesthesiology. You see, we work together with Harvard University, the Queensland Brain Institute, yeah, and I think the title, Time to Wake Up, the Ongoing Search for General Anesthesia Reversal Patients. This is another one of our publications in the Medical Journal of Australia, and this is in Anesthesia Analgesia, presynaptic neurotransmission, the bottleneck to recovery from general anesthesia. Yeah, so now for many years I was doing all kinds of research of this one, and it now has attracted national and international attention, and I got many awards for all these discoveries. For instance, this is from FANZCA, the Australian New Zealand College of Anaesthetists, with the president. They gave me all kinds of medals, as you can see. This is the FANZCA medal, this is the Australian medal, and this, I'm a Belgian born, Belgium in north of France, in Europe, and His Majesty the King gave me this commander in the Order of the Royal Crown for my contributions to medicine. This is the University of Queensland. University of Queensland gave me their highest diploma, and it's a doctorate of medicine by research. So you have your medical diploma, you have a PhD diploma, and there's one level above. That's a doctorate of medicine by research. It's only given to one person among the whole faculty of medicine once every 3 years. So it's very unique. I must say I was flabbergasted to receive it based on my contributions to medicine. And so they made me also the Professor Leonard Travers from FANZCA, and this one is very important. You have the Australian Medical Association. There's about 150,000 doctors in Australia. Every year they choose one doctor who got their highest award, the Excellence in Healthcare Award, for contributions to medicine and excellence in healthcare. So that was also very prestigious. You see, that's the award things. International, achievements at the Indo-Anesthesia meeting. This is the Carl Coller Gold Medal Award. That's in Europe. You see that? That's in Oslo last year. And this one just happened 1 week ago. 1 week ago I was in China because I was invited by the Chinese Academy of Sciences. The Chinese Academy of Sciences is probably the most important scientific institution at this particular moment in the world. Yeah, it's the Silicon Valley of science. You understand? And this person, he is from the Chinese Academy of Sciences. He's also some important person at the United Nations. I don't know all these things, but anyway, they developed, let me see where it is. The André van Zundert Research and Education Center. So they named the whole institution after me for my contributions to medicine, anesthesia, and you name it. So it's now a research center, education center, yeah, with all kinds of people. And it's at the Shenzhen Institute of Advanced Technology. You know Hong Kong, at the other side of the river, we have Shenzhen. It's unbelievable how much money the Chinese government is putting in these kind of institutions. I was really flabbergasted seeing that. That happened just a week ago. You see that in the 2 languages? Anyway, I'm also the editor-in-chief of healthcare, as you can see in here. And we got a Q1 level scoring system for leadership and management in healthcare. So I'm flabbergasted by that amazing brain. I learn each and every time more of these kind of things. And I think the success, what we have, yeah, there's an enormous clinical impact. If we can provide better anesthesia without, look, if you have a surgical intervention, okay, at a certain point of time, the surgeon stops and says, I'm ready. Why should the patient still be under anesthesia? There's no reason. If we can do it faster, maybe the patient can go home faster. Yeah, the turnover in operating theaters can much higher. It will save costs to the hospital. They can use that money to treat other patients or to do whatever other things. Yeah? If you undergo anesthesia at this particular moment, you are not allowed to drive home, you are not allowed to sign any contract, yeah? You need help from somebody else. Suppose our mechanisms are working much better, that we can awaken the patient much faster, maybe they can drive home again themselves, yeah? And can do all kinds of other things. So it has an effect on 400 million patients undergoing anesthesia, general anesthesia. Every year we have worldwide 400 million general anesthetics. So the impact can be enormous, you understand? And that, well, there are not that many things, yeah, that have such a big impact. So world medicine will improve. Yeah? We have not only the clinical impact, but also the academic impact. We understand now these methods, yeah, how they work. And now we can produce antidotes, reversal agents. So that is what we are doing with high impact. You see, we publish in anesthesiology, in anesthesiology, and you name it. Yeah? And citations of our work is going on very fast. It has also a society and community impact. It is good that patients or consumers are aware of what we are doing. That they see, okay, we put a lot of energy to understand better these mechanisms, to deliver a much better, more efficient and safer anesthetic to the patient. It has also policy impact, clinical guidelines, etc. needs to be developed, and it has an economical impact, cost savings, yeah, which is very important. So we come a long way, not understanding, yeah, how the working mechanisms really, general anesthesia really works. It was a passive process. And I come from a time, you see my the color of my hair, that we were using pentothal as an induction agent. And the hangover was at least 24 hours. So patient didn't go home the same day. That doesn't happen. Nowadays it's normal. But in those days, no. If you have to undergo a gallbladder surgery, you had to stay 3 weeks in the hospital. 3 weeks in the hospital. I developed techniques where the patient can go home the same day. You understand the difference? So it's very important to understand this passive process. Now I think we can make it a little bit more active. And this is the kind of patient that you want to see immediately after anesthesia. Okay? So the first revolution was the discovery of general anesthetics in 1846. And I think we are at the start of the second revolution with the discovery of reversal agent. So time to wake up. That is what we need to do. Okay? Thank you for your attention.
Thank you, Prof. Andre, for delivering the first topic about working mechanism of general anesthetic and reversal agents. Where do we stand? So thank you, Prof. Andre, for sharing your research and new perspective that we actually in Indonesia is thoroughly heard of. So before we continue to the second topic, I would like to introduce our moderator of today, our respected teacher, Dr. Imade Prema, Specialist Anesthesia Therapy Intensive. Dr. Prema will guide us through the lecture sessions and will guide us to our teacher and speaker. So Dr. Prema, the floor is yours. Please guide us to the second sessions and until the fourth session.
Thank you very much. The question is whether BIS monitoring is now adequate enough. We want to monitor everything. We know all the ventilatory aspect, the hematology aspect, temperature, you name it. We measure that. We have not a very good monitoring of our brains. Of course, we can do EEG. When I was a trainee in cardiac anesthesia and thoracic anesthesia for heart operations, each and every patient had to be monitored with an EEG. But that required also a person who knew how to diagnose EEG abnormalities. And we were not enough trained because it took 5 to 7 years to do the training of EEG. So that's not a very easy way for us anesthesiologists to monitor. We are using BIS monitor, but BIS monitoring has several disadvantages. Nowadays, one of my PhD students is using digital subscription angiography. It seems to be that it is more effective. I don't have a slide with me, but you can see a sort of a colorful thing as a monitor, and that gives you an indication what is the depth of anesthesia. Because that ultimately is what we need. We need to have a monitor, how deep is the patient? Because if you're awake, you give a little bit of sedation, a little bit of sedation, but if you give anesthesia, you're at a deeper level, and if you give too much, they are really comatose, and if you give far too much, you're dead. That's not what we want. We want to have the right level, the right depth of anesthesia according to what is the need for that particular intervention. But we are working on it, but we have not found the final solution as yet. So it's an ongoing process, and hopefully we understand it better in the future and that we can have these monitors.
Good morning, Prof. I hope you have a nice day today in Bali.
Thank you.
Good. My name is Krishna. I would like to ask you, or would you please give further explanation about the mechanism of action of this Propofol, you said, right? Is it actually how it's kick off Propofol from its receptor? Is it like binding with the Propofol, like Sugamadec and Roculak, or is just competitive with that receptor? Thank you very much.
Thank you for this interesting question, because how does it really work? You've seen the syntaxin with the sticky fingers. On top of that, we have the MUNC18 protein, the chaperone protein, so that it can be transported towards that vesicle. You've seen that. Okay, what exactly is it? It's not a biochemical metabolism. No, it just kicks out the propofol. Yeah, because the propofol sits between that syntaxin and the MUNC protein. Okay, preventing it from transport. It paralyzes it. Now, what the propofluor, the reversal agent, does, it kicks it out. So the propofol is kicked out, and now there's that reversal agent, and it has no paralyzing effects. So the syntaxin can still move towards that vesicle. You understand? So it's not a chemical reaction, it's just yeah, a mechanical thing. Yeah, so it needs to be in the majority. You understand?
May I ask further a little bit, Prof? If it like that, that's mean right now here we are in neuro anesthesia. We actually have sometimes a problem that when the beat is too low, I mean it's much more less than 20, for example, and that is make inflammation, of course, on the brain. So with this, I think it can help then to make the beat become higher or something like that.
Yeah. So it sits in between those two, and this sits on top, and the propofol, yeah, is a tiny thing that sits just in between those two. If we can, well, I'm not sure whether I can go back that far, but remember the GABA protein, it was just a tiny thing at the propofol. Remember that? I need to go back, sorry. Yeah. This is the GABA receptor. It's a huge thing, as you can see here, and an anesthetic is a very tiny thing. Please understand, with the syntaxin and the MUNC protein, it's a very tiny thing, but that paralyzes the whole complex. You understand? So little tiny things, but they have an enormous impact. Pleasure. Thank you very much. Now, we were talking about Propofol, we are talking about reversal agents, but I'm also talking about a new induction agent in anesthesia. And I believe it will be the end of the Propofol. So I'm going to propose a new one. Okay? You see, it's a long list of my, and you see, Udayana University, then Passar. I'm always listing it as well because I'm pleased to be here. Now, this is my talk, the Propofol paradox, introducing a new drug with mechanism, pharmacology, safety, high-risk patients, and future direction. So I'm going to talk about a successor of Propofol. And I'm pretty sure in 5 to 7 years you are going to use no longer Propofol, but a new one. Let me explain why that is. This is Propofol. You're using Propofol, I think, all the time, isn't it? And they have benefits. We all know they have benefits. They work very fast. They have a duration of action. And if you stop, the patient wakes up after a certain time. Yeah? It gives you sedation. It gives you anamnesia. Yeah? And you can give it as a bolus dose, as a continuous infusion, whatever. Okay? But it has also side effects. Pain at the injection site. When Propofol was introduced in anesthesia, or I think it was the 1990s or so, the first formula was very painful on injection. That was the reason we had to add on things like lidocaine or fentanyl to make sure that it is not so painful. So they redesigned the Propofol formula in those days, yeah, but still 70% of our patients have injection pain. And that's not something that you can use in children. Children will react very fast. So you see all these kind of things, you know, that the metabolism, etc. Okay? So this is the formula, the phenol, with 2 isopropyl groups. See that here? And it has an advantages, rapid induction, do not sensitize does not sensitize myocardium to adrenaline, no nausea and vomiting, non-explosive. It can give as a continuum total intravenous anesthesia. Yeah, but it has disadvantages as well. Induction apnea, post-induction hypotension due to the vasodilatation, bradycardia can occur, respiratory depression, pain, etc. So can we find a new drug that is maybe not so, has not all these disadvantages? And of course, we know about in Harvard Medical the Propofol, the drug that killed Michael Jackson. And I'm aware of patients, not patients, team members in the hospital who were misusing Propofol. And I remember in Europe there was a sort of a technician who used the Propofol to suicide himself. So it happens. So it's a very powerful drug. As you can see here, the Propofol, this is the formula here, and we have the Propofol, as you can see here. And we have our publications list here. Now, Propofol, so established in 1990, the AstraZeneca. You had the Astra company in Sweden, and the Zeneca company in the United Kingdoms, and they merged together and produced a new company. And they only had one drug at the beginning, Propofol. I don't know all the history about the company, but anyway, that was their main drug. And it's headquartered now in Cambridge in the United Kingdom. Now in China, the High Score pharmaceutical company, this is the company, they produced a sort of a, I'm going back, you see that here? This is very symmetrical. And what they did, they changed one group. You see that in this one here. And we call that Ciprofol. Ciprofol, yeah, developed by this company. Yeah, it's the first new drug now as a successor of the Propofol. Okay, so what you see, Propofol, this is the formula, D-isopropylphenol, and this is the same on this side, but this is different. You see, cyclopropylethyl, cyclopropylethyl. So it's now asymmetric. Understand? Now we looked at these differences. You see the cyprofol and the propofol, and you see that it retains the core structure framework of propofol, but the key modification is the replacement of that isopropyl substitute by the cyclopropylethyl. That is what is happening. Now, the experiments that they have done thus far, to understand the pharmacological mechanism, you see it binds on GABA. See the GABA here? Okay? Propofol binds a little bit, low affinity. The ciprofol binds much harder, so high affinity. Okay? So the power of the new drug is 5 times that of propofol. Much more powerful induction agent than what we had thus far. So the propofol, this is the ciprofol. The ciprofol is 5 times as potent. Much more potent than, and that's only on the GABA receptor. They have not studied yet on the presynaptic, but this is one of the actions. You see? So ciprofol is much stronger anesthetic than propofol, allowing for lower clinical doses. If you have to give lower doses, most probably the patient will wake up much faster, don't you think so? And it has more stable hemodynamics, safer anesthesia induction, greater patient acceptance, 5 times as potent as propofol, and a lower incidence of respiratory adverse effect, injection pain, and post-induction hypotension. Because that's a nuisance to us. If we inject propofol and we see the blood pressure is decreasing, that's not what we want, because then we have to react. We have to give vasopressors, fluids, and you name it. Okay? Milder effects on the cardiovascular system, and it can be used in all kinds of systems. You see, this is propofol dosing. Propofol dosing, you see that is the success rate of induction of anesthesia, and this is a propofol dosing. 2.5 milligrams per kilograms, yeah? That compares to 0.5. So 2.5 milligrams per kilogram of the propofol is the same as 0.5 milligram of ciprofol. See, the doses that you have to administer is 5 times less. This is in anesthesiology, and they looked at the pain scores. Okay, there are different studies, and don't forget these are initial studies. First experience with the new drug. And you see, propofol, 77% of the patient had injection pain, with the ciprofol, 18%. Here another study, 61%, and here it is 6%. Okay, so much difference between adverse effects. And the same is true. Ciprofol reduced the incidence of post-induction hypotension by at least 35%. So less hypotension in these studies. That was in the JAMA. Ciprofol compared to propofol, a systematic review, and what you see, ciprofol versus propofol for sedation general anesthesia in 14 RCTs, because this is a Chinese drug. All these experiments are done in China. You see RCTs here, and ciprofol pharmacokinetics seems characterized by a slower onset and offset as compared to propofol. These were the initial things, but that depends also on the doses that you are giving. Pain was significantly less. That was immediately evident, and adverse effect with ciprofol, much lower adverse effects. This is rather complicated, but what you see, the binding, the affinity of ciprofol for instance, the GABA receptor is much stronger. This is also pharmacological studies, and the ciprofol demonstrates several clinical advantages: higher anesthesia success rate, a reduced injection pain, better cardiovascular stability, more favorable option for clinical cases like elderly patients, etc. So that gives already a huge advantage, yeah, of these studies. And this is, for instance, another study, yeah, a meta-analysis comparing Ciprofol versus Propofol. So you have the Ciprofol, and here's the Propofol, and you see there are certainly advantages. You see how much better it is for pain during injection, yeah, almost none, yeah, compared to Propofol. Yeah, and all the advantages, hypotension, it's much better for Ciprofol compared to Propofol. So if you see that it has a more powerful effect with less side effects, aren't you going to use that product in the future? I'm pretty sure you are going to do that. And you see very clear the pain on injection here as well. Anesthesia success. It's Ciprofol is doing a better job with less side effects, yeah, and it has at least the same effects, so it's non-inferior to Propofol. And it goes on and on and on. You see induction time, non-inferior, time being fully alert, it's non-inferior, so it's going to help you. And in fact, the Ciprofol has a better impact than Propofol, less bradycardia, less post-induction hypotension, less respiratory depression, less hypoxemia, and less injection pain. And it's non-inferior for these kinds of things. So I don't see any disadvantage, yeah, in using the Ciprofol. Now let's look for a meta-analysis on elderly patients. And you see the same, yeah? A reduced incidence of hypotension, respiratory depression, hypoxemia, injection pain, involuntary movements, nausea and vomiting, and a few others which are non-inferior. This is a group of patients with severe aortic stenosis. You know, if we do an injection, in these kinds of patients, the blood pressure usually goes very fast. Yeah? And it seems to be, this is a Ciprofol study, this is a Propofol study, that's Ciprofol, another name is Ciprofol, provide a superior hemodynamics. That is what we want in these very vulnerable patients with aortic stenosis, as you can see here. We do not want to have that blood pressure drop because it's devastating. And again, all kinds of things. You see, injection pain is better for Ciprofol. And there's not too much on this side that this favors the Propofol. So huge number of these tests are done, and the meta-analysis proves that it is a good working mechanism. Cardiovascular responses to tracheal intubation. Again, much less than with Propofol. Yeah? So we see all these advantages in green and the non-inferior advantages, yeah, in yellow, as you can see here. Okay? So, and especially in the elderly, yeah, you see the duration of anesthesia was the same, total doses given. So it's very comparable group, but you still see Ciprofol is doing much better than Propofol. So Ciprofol can safely be and effectively be used in the elderly patient. And that's good. Yeah, so a group of 1,600 elderly patients, meta-analysis, you see the incidence of post-induction hypotension with Ciprofol is less than with Propofol. Respiratory depression, hypoxemia, injection pain, involuntary movement, nausea, and vomiting. Okay, so I started writing up, for instance, the induction doses. It's 5 times less than the Propofol. The therapeutic index, the safety of your drugs, is much higher than with Propofol. In order to kill somebody with Propofol, it's easy. It's less easy with Cyclophob. Yeah. Okay. So the standard incidence of injection pain, we know that this is reduced. Dose-dependent post-induction hypotension with Propofol, it's lower. Bradycardia happens with Propofol, is hardly insignificant here, and we have dose-dependent respiratory depression, and the incidence with ciprofol is much less. So the pharmacological mechanisms and the clinical applications, they are well known nowadays. Yeah? And the incidence of post-nausea and vomiting, which is important. There are 2 audits in my institution, and that's post-operative nausea and vomiting and temperature. Patient cannot go to the recovery room if they have a low temperature. Okay? So, and you see, it's a safe use of ciprofol and propofol. Ciprofol attenuates the isoproterenol-induced oxidative damage and inflammatory response on the cardiomyocyte apoptosis. What does that mean? It tells you that ciprofol even protects the heart against myocardial infarction. And that's a big benefit, I think. So there are side effects of propofol, ciprofol. Compared to propofol, they are insignificant. Yeah? And for that reason, I think we will change the introduction in a couple of years from propofol to ciprofol. All the systematic reviews, the RCTs, the meta-analysis, they focus in the same direction, that pain is less, lower incidence of adverse effects of propofol. And it seems that the ciprofol is much safer. Yeah, it's certainly an advancement. It gives better safety for our patient and minimal need for dose adjustment. So this is a number of studies that I've studied myself to understand better the mechanisms of ciprofol. So I think in the future we are going to make a change from this drug to that drug, and I hope it will be, well, I'm convinced that that new drug will have a bright future. Thank you very much for your attention.
Thank you very much, Prof, for the times. Me again, the Isna. I would like to ask you, Prof. I have 2 questions. The first one, I would like to know about this Propofol you said, right? How about the context-sensitive half times? Is it
Sorry, can you repeat that last word?
a context-sensitive half time?
Mhm.
Do you context-sensitive half time? I mean, like, how much is the drug will be 50% after the continuous infusion is stopped? Right? Because I interested in that, because context-sensitive half time is one thing that we have to know about when using this with the TCI. So I like to see this drug can be used using a TCI later on. That is my first questions.
Yeah.
My second
Can
question.
I just answer the first one, otherwise I will forget the rest. Yeah, I think it's an important question. Yeah, the context sensitivity time is reduced. Now, I'm not an expert in pharmacology. I've seen articles on pharmacology who are proving this item. But this is just the beginning. Don't forget, this drug exists for a couple of years. There are now initial experiments, yeah, and we need to have big experiments, big trials, yeah, not only in China, but also in the rest of the world. And I presume, I've heard that the FDA is going to approve it in the United States by the end of this year. So we are going to see more of these major trials. That is what we need. On top of that, in my institution, we are doing already the ciprofluor. You understand what I want to say? So propofluor is a reversal agent, and we are working now also with the ciprofluor as a reversal agent, with the intent of to make it even shorter working. So again, most of these experiments have the idea that it only works on GABA receptor. That's not correct. It works on GABA receptor, yes, but also on mitochondria, also on calcium, also on the presynaptic machinery. And there may be a difference between that. Maybe the ciprofol works more on the presynaptic machinery, because the GABA receptor, if you inject a little bit of propofol, the GABA receptor is the first to stop working, okay? But if you want to have anesthesia for surgery, you need to stop working the presynaptic transmitter release machinery. You understand the different grades? So that is important. I hope I have given you a little bit of explanation, but the real pharmacokinetic analysis, yeah, it's not really my thing. Yeah, you do understand that requires a different experience level.
Thank you very much, Prof. Actually, my second question is already answered by you. I just would like to ask if the Propofol will work with this ciprofol. So you said that just now you already advantage the ciprofol. So I think this is a good, it's an interesting mind. About this, because this will be great in the future. Thank you very much, Prof.
Thank you very much. Can you put up the third? Sorry, I did not get it completely. Can you? So do I get it right? What is the most important factor for the introduction of ciprofol into the clinical practice compared to propofol? Yeah. It can be, well, new drugs usually come with a new cost price. It can be that the cost price, I don't know, yeah, of the ciprofol is higher. I don't know, yeah, because it's only in China. We don't know how it is outside of China. So the production of a new pharmaceutical drug is usually in the billions of US dollars. Yeah? That needs to be transformed later on if we purchase this medication, and we have to pay a price for it. So I think that is the most important aspect. If I see, and I've read at least 30, maybe 40 of these publications, yeah, if I see all the benefits of it, and I don't see any drawbacks and side effects, then I really think we are at the start of a new evolution in anesthesia, and that we will have a new drug. Yeah? And I must say, in my career, I've seen the development of new drugs. I'm not going to list them all, but I'm sure that from ether, chloroform, isoflurane, pentrain, you name it, E-train, I've seen them all. Yeah? But each and every time when we have a new drug, we forget about the old drugs. And we do that the same with general anesthetics, induction agents, from pentothal, epontol, etomidate, propofol, and now we will have ciprofol. So there's an evolution, and that's good. Each and every time we want to improve our service to our patients, okay? And that is what we need to do. We need to have people coming up with new ideas, and I hope one of you will be in the future also involved in that kind of experiment. Thank you. Thank you very much. This is a very hot topic. I was asked by the Mexican Society of Anesthesiology to give a lecture on safety in obstetric anesthesia. And in fact, I need to go back till the years, I think, early 1990s. In those days, I wrote my PhD thesis in 1985. I defended it. And that was in what is the safe doses to be used in obstetric epidural analgesia. And I published in those days in Anaesthesiology, every dose in epidural analgesia should be a test dose. And I'm really convinced that is the key of the safety factor in obstetric anesthesia. And in those days, Albright and others, they published why are so many women dying in labor when they have an epidural. And the reason was that they were using far too much. They were using bupivacaine 0.5% in the United States. They were using bupivacaine 0.25% in the UK. And I came with a very different solution, 0.125%. And I could demonstrate the safety of it. Even if you give 10 milliliter of that formula into the epidural space, it will work. If you give it into the spinal space, 10 milliliter of that solution into the subarachnoid space, it will work, and you even can do a cesarean section. Okay? If you inject it intravenously, that was the cause of many of the deaths in those days, it's still safe. But if you monitor the heart rate and the blood pressure, you will see there's a spike, very temporary spike in the blood pressure and the tachycardia if you use that doses. So I came up with the ideal test dose in obstetric epidural anesthesia, but also in all epidural anesthesia or regional anesthesia blocks. And that made, well, that had as a consequence that I was asked to come as a professor to Harvard University. So I became a professor at Harvard University, and I wrote my first big textbook, 1,100 pages, on how to improve effective and safe epidural analgesia in obstetrics. So not only to be used in an epidural space, but also in the subarachnoid space, and if you use it intravenously by accident, because our catheters sometimes are inserted into a vein. And if that is the case, then you will end up with a catastrophe. Okay? So that is a little bit of the background. So in the 1990s, I was already at Harvard University in Boston, Massachusetts. At Harvard University, I was a professor later at Yale University and much later at Toronto University. And that was one of the foundations how I developed later on my career. Okay? So, based on that, the Mexican Society of Anesthesiologists, this one here, asked me a couple of years ago, can you give a lecture on how to improve safety in epidural and spinal anesthesia in Mexico? Because they have had the largest outbreak of deaths, yeah, in Mexico in modern times. So we are talking about just a few years from now. Okay? So what was happening? Meningitis. A huge number of women developed meningitis due to a Fusarium solani. Fusarium solani is a fungus. Now, we usually have meningitis due to bacterial infections, viral infections, but you will see that in a couple of days, maybe in a week. But this one, you will see, it comes sometimes after months. Nobody thinks about the cesarean section anymore. Yeah? Months later, these women develop all kinds of problems. Okay? And you see, it started in September 22, all the way till February 23. The majority of deaths, you see all the black things here, happened in that first period because they did not realize, they did not diagnose it was a fungal infection. See that? So later on was the number of deaths decreased. So what is happening? This is Durango, Mexico. I will show you in a minute. For cesarean deliveries, women came to the hospital and they were given a spinal or an epidural. See, this is an epidural. And this is the first case, a 19-year-old woman, no medical condition whatsoever, pregnancy uncomplicated, no sign of anything, everything was normal. And so she underwent an elective cesarean section for safe delivery. Now I found out that in the private sector, women deliver by cesarean section in almost 90% of the cases. So very few have vaginal delivery. Okay? They were using medication that was injected here, and as you can see, August 23, C-section, administered, healthy baby was born, mother recovered well, nothing happened. Till 80 days later, nobody was thinking about the cesarean anymore. You see, she was in a stable condition, discharged, no problems, and then you see that is August 25, this is November, 80 days later, persistent severe headache, neck stiffness, nausea and vomiting, indicators of meningitis. Okay, and she was admitted to the hospital. They did a lumbar puncture, and they said, okay, there might be signs of infections, and microbiological test positive for that fungus. Okay, they did a head CT, no abnormalities. They did not really start a treatment. It's not that easy because what exactly is the treatment of these kinds of meningitis? So we are now, so it was August, now we are late November, deterioration, severe subarachnoid hemorrhage, you see the CT scan here, severe intracranial hemorrhage, and on 30th of November, the patient died. That's very unfortunate, obviously. It was not the only patient. You will see in Mexico alone, about 50 patients died, and later in Argentina, about 100 patients died of the same thing, in Chile, in Colombia, and you name it. All restricted to South America and Mid-America. And they had lots of protests ongoing because of what is happening. And it indeed is very difficult. You see, this is the border with the United States. The United States here. This is Mexico. And we have the first outbreak in Durango, so western part. Okay? So that is, so by November the 4th, the first year, we had 11 unexpected meningitis cases reported to the World Health Organization. All of them Fusarium solani. Okay? And you see, in January 23, the total cases reached 80, and these were all the deaths. It was a significant thing. And so 30 deaths already in January 23. And what you see, the first thing is that the government took and put lots and lots of people into jail. And that is a wrong thing. And that is one of the, hopefully, the take-home messages. If there's an incident happening, and hospitals, every day we have incidents. Every day something goes wrong in a hospital. But does that mean you have to blame the doctor or the nurse? No, that is not correct. You have to look in a broader picture. You have to look at system errors. Why all of a sudden they have these kind of problems? There must be something extraordinary that is not due to the anesthesiologist, but due to the system. I'll come to that later. That is what we call safety 1 and safety 2 procedures. Safety 1, that is when you look at one error. Yeah? You are trying to find what went wrong. Whereas safety 2 mechanism is what went right and what caused all these problems. Because this doctor maybe has given regional anesthesia blocks for 10, 20, 25 years, and why all of a sudden he has this problem? Does that mean that he is a bad doctor? No. We need to have our open eyes and focus not only on what went wrong, but how we can learn from it to prevent things from happening in the future. And that is absolutely what they didn't do in Mexico. They focused, oh, the doctor is wrong, we put him in jail. Does that help anybody? For sure not. Does that help the women? No. You have to investigate what is going wrong. You have to put energy in it and find all the steps. Yeah? And I'll come to that later on. So you see the number of deaths here. Yeah? They put arrest begin. 3 individuals were arrested, including an anesthesiologist. And the public started to demand for justice. They said, how is that possible? 19-year-old, and why would you die from that? That is not good. Okay? So, it started here in Durango, but then we had in Matamoros, just this is Texas here, just below Texas, we had another outbreak. And they were asking me as one of the international experts, but also people from the FDA, because this particular area is Matamoros. Matamoros is just on the other side of the border, and people from Texas are going to Mexico because it's cheaper for their deliveries or their surgeries, you know. This is what we call medical tourism, and medical tourism happens in the whole world. I mean, it may even happen here, I don't know, yeah? But I'm sure it happens in Malaysia, in Singapore, of all the countries here, yeah? Medical tourism happens. Now, Australia is a very expensive country, but if they come and be operated here, it's much cheaper. And I think there's an international new hospital here developed. Is it specifically for the Australians? I'm not 100% sure. No, but anyway, it's a new hospital. I've seen it 2 years ago. They were building it, yeah, with the intention to attract people from overseas, so that, yeah, it's much cheaper for them to get their operations here. Yeah? So that's what's happening here in Matamoros. Yeah? People from the United States coming here because it's cheaper. But after the delivery or after the operation, they went back to the United States. But now, 2 months later, they died in the United States. And that got the attention from the FDA, the Federal Drug Administration. And they said, well, what's happening in Mexico? Yeah, all these patients are dying. And so now started the FDA, and you can imagine that's a big investigation. So they formed an international group of experts. So I was one of them, but you have many professors from the United States and from several other places in the world. And we had to investigate what is happening here. And I think that's very clever. to not only focus on the doctor what he did wrong, because that's not going to solve the problem, but to see the whole mechanism behind it, from the production process by the pharmaceutical delivery till how it is delivered to the hospital, how it is delivered to the pharmacy, how the pharmacy is keeping it in the hospital in a clean, sterile way, how the drug is then sent to the operating theaters, what kind of precautions the anesthesiologist is taking and the nurses are taking. That whole range needs to be done. It's everything hygienic precaution taken by the anesthesiologist, cleaning the back with antisepsis, etc. Make sure that it is not out of date, that it is the prescription of the drug is within the normal date, no expiry date. All kinds of things. And we found astonishing things. We found that in Mexico, for instance, the production of certain drugs was not checked. That's not a good thing, of course. It needs to be checked on a regular basis. That's basic science, I think, and check it from the start till the very end of the use of these drugs. Anyway, so in the United States, there was even travel warnings. No medical tourism should be done, which is bad, of course, for Mexico. And you see, this was 7 confirmed deaths in the United States. But these were women traveling on medical tourism, and they were found deaths. So we had now already 115 confirmed cases, and half of them were dead. That's very odd, isn't it? That is something you would not like. At the same time, already 7 healthcare professionals were in prison. Very odd thing in Mexico. Even us, as international experts, we had no access to the files. The government protected themselves and said, no, you're not going to see these kind of things. If you have no openness, how can you really find out about all these things? Okay? So, meanwhile, it became the largest cluster of fungal meningitis incidents in the history of anesthesia. We published, you see a few here, you see in the American Society of Anesthesiology Monitor, we published this kind of thing to better understand what we can do in order to prevent these kind of things from happening. And again, protests everywhere, as you can see. We have Durango and we have Metamoras. I'm not going to detail, but one of the things that you need to do if you have such a complex thing is root cause analysis. Analysis of the root cause, that is important. Another thing is the failure mode and effects analysis. This is a very complex thing that we apply in cases like this. So we really look at every potential human factor that is possible. Okay? So the workflow, it is completely diagnosed. It took us a long effort and a long time investment to do that. So what you need to do, if you have an incident like that, that you look at the root cause analysis. You look at AXIMAP. You look at failure mode and effects analysis like this one. And you look at journey mapping. Journey mapping, I will discuss that in my next lecture. Okay? So, in individuals that were imprisoned were, for instance, an administrator, the owner of hospitals, because it was very odd that these anesthesiologists were working in different hospitals, private hospitals. Yeah? And what they were using, big ampoules, large ampoules, not for one patient, but they were used on several patients. That's very odd. It's forbidden in Australia, and I think it's forbidden here that you can use one vial for different patients. It's not allowed here, which is a good thing. And I think medication should be restricted for one patient and one patient only. But what did these anesthetists did, and I think Mexico has a bit the same climate as here. It's warm, it's humid, and if they use, they have to buy their own medication. They have to use, for instance, morphine or bupivacaine. They have to buy it themselves, bring it to the hospital, and then use it on the patient in the theater. But to save money, what did they do? Big ampoules and go from one hospital to the next hospital and we use it on the next patient. And that is not good. You should not do that. So one of the first things that we advised, in Mexico, no longer production of big ampoules. So nowadays in Mexico you will not find it. So that's due to our recommendation. Just single vials for one patient and not for multiple other patients. So you see, administrators, owner of hospital, they're all in prison. And then the patient came up. So we provided a drug visual inspection checklist. You see, for induction agent, neuromuscular opioids, all these drugs that you're using everywhere. You can just do the checklist here. But you see, for instance, if they were using morphine, 15 milligrams per milliliter, you see a big file here. You cannot use that on one patient. That's far too much. But if that gets infected, you do understand that will affect many patients if you are going to use it on many patients. So don't use it at all. Furthermore, there are different, for instance, this is fentanyl. If there's such a large variety in all kinds of doses, all kinds of concentrations, that is prone to make it difficult. You understand? Because not everybody has the same level as you, and perhaps your nursing staff may not know the difference between this one and that one. And if they prepare the medication, you're going to give maybe an overdose. You understand? And just last month I published in the British Journal of Anaesthesia, Optimizing Operating Theatre Compromises Anesthetic Safety, Ambient Lighting, Human Performance and Medication Errors. Perhaps you should read that, because I'm not too sure whether you're using ambient light systems for your operations, where you have maybe yellow light, green light, blue light. You have these kinds of operations as well, where surgeons want to do operations with very strict the lineup between normal tissue and cancer tissues. Okay, and they use ambient light, blue light, green light, and sometimes you can't understand. Look, this is in normal daylight, white light, like here, and this is in blue light. But can you distinguish now the drugs? It's much harder. And I published an article, I think last year, in Anesthesia and Analgesia, that you need to avoid these kind of things. Okay? And you see some of the medications which are completely different, and they look very similar. You see that? So all kinds of drugs, that's what I wrote in that editorial in the British Journal of Anaesthesia. Human factors are so important. And don't blame the anesthesiologist, because the whole system needs to be evaluated. So we call it work as imagined and work as done. The work as done, that is your situation. Today you are giving anesthesia to a particular patient with a history of whatever of diseases, for that particular surgery. That is what we call work as done. Work as done, that's how you do in this particular situation. You have administered so much anesthetics, etc. Whereas work as imagined, that's in the textbook. The ideal situation, the ideal patient with no problems whatsoever, and you give an ideal anesthetic. But that's not the reality. That's textbook. And I wrote myself 8 textbooks, so I know how it works. But that doesn't mean that it is always correct. That's the ideal situation. We all drive in the same direction on the road, but sometimes we take a little bit like this, a turn. And that is work as done. you need to learn from your mistakes, yeah, and you need to add on tasks or refuse to do tasks. So system errors, that is so important. Not only the blame technique, the blame culture, that is not good for a department. If you use a blame culture, that means staff will not admit something went wrong, because maybe they end up in jail like in Mexico. That's not what you want to do. So you need to have a just culture. That means if something goes wrong, yeah, ask help from a colleague and to solve the issue, or maybe the director of the department, so that he can help preventing these things from happening in the future. So work as done, that is important. That's what you are doing every day, and not work as imagined. That's the textbook. Okay, and there are all kinds of other works as done, but I just want to say, avoid the blame culture. A blame culture in a department is killing for the department. Yeah, make sure that people can stand up and say, sorry, I had an incident, can you help me to prevent this from happening in the future? That is my message I want to bring. And there are many things that can go wrong here. I'm not going to do that, but these are human factors. We are human beings. That means we are fallible. Yeah? We can have incidents. We can have problems, complications. But the department should support you, not use a finger blame technique. So that's what I'm talking about, safety. Safety 1 procedures and safety 2 procedures. This is more modern. This is the old way. This was the blame technique. That, you had a complication in a patient, for instance, central eye, and you had in an artery. Yeah? Or you had an epidural, but you ended up with a spinal tap. Or you had an endotracheal tube, and you intubated the esophagus. Okay? That is safety 1. Blaming the doctor, blaming the nurse. That is not good. You understand? It does not help the patient. It does not help the doctor. He will be depressed. He will have all kinds of psychological issues if we don't help them. There should be a culture of support to do that. That is very important. So instead of blaming, look at things which went well, which went, yeah, all the good things. There are many things in a whole case that went well. Look at those things and try to improve, yeah, the human factors, the system errors, because there are always system errors. Perhaps the ultrasound machine was not working optimally. Perhaps there was a light error, or nursing staff shortage, or senior anesthetist shortage. Yeah? There are always human factors here and system errors. And look at these and try to improve them. And that is what is medicine all the time. We try to improve our things, the things that we are doing every day. Okay? So, for instance, the safety that we saw in Mexico, that's about the sterilization. We listed a number of things that they needed to improve. We are doing that now, which is important. Huh? You see all the whole production process of medication, that is good now, so that there's no contact anymore of this fusarium. Because of the fungus Fusarium solani, everybody has that fungus. All of us have the fungus, but usually it's not a problem. Yeah? And especially if you have a horse stable next to the hospital, what was the case in Durango, we had a horse stable next to the hospital, and the hospital has undergone refurbishment, but they did not use the air conditioning system for months during the refurbishment. Yeah? But the fungus was transported via the air conditioning, and when they reopened, they had all these kinds of cases. On top of that, it was also morphine vials which were infected by the fungus. So is anesthesia dangerous? Yes, it is dangerous. Don't forget in 1900, 1 in 2 patients did not survive an operation. Nowadays, anesthesia is very much safer. And each and every day we improve safety measures. We introduce safety measures. Yeah? And compared to 30 years ago, the mortality rate has come down substantially. And we all know that. It is very safe because we are working hard. In the time 100 years ago, when the surgeons were also the anesthetists of the case, many things went wrong. And it was clever of the surgeons to take the decision that in those days, we as surgeons no longer are going to take care of the anesthesia, let it be done by somebody else. I think that was a very clever idea. So be aware, fatal accidents, incidents can occur. Thank you very much for your attention. The next lecture is a little bit linked to this one. Perhaps I can give that one first. Yeah. Now I have 2 lectures to go. Okay, because it's linked to this, and I want you to share what we often forget is we are looking at the whole system, at the hospital system. We are looking at nursing staff, management, doctors, but we forget quite often the input of patients. And this is what we call journey mapping. Journey mapping is now looking the involvement of our customers. Our customers are very important, otherwise we have no job. Our customers, the patient, and let them have a say as well. That is what I'm going to introduce here. So we had that large infection with lots of people, Metamoras and Durango. Remember from the last. And that was catastrophic. See, this is the Mexico here. Yeah. So Metamoras here, just south of Texas, and the other one was in Durango on this side. Okay. So now the study aim of a journal mapping is look at the whole trajectory, where the patient needs to be involved in understanding what we can do better for them. Okay, patients are not just recipients of care, but they are also observers of us. They have a feeling. They also have signs and symptoms, which we can use to make a diagnostic. They can identify hazards, and you will see that sometimes they have a better idea of what's going wrong than what we have, okay, in the care. So we call that journey mapping, offers a structural way to analyze these experiences. So human factors framing, I told you already, it's very important, yeah. And why is this a system failure? Okay, so there are all kinds of methods. I'm not going too deep into that, but we did survivors interviewed with 4 of these survivors. So as you can see, half of the patient died, but half of them survived. Now, we were lucky to be able to do 4 interviews with those survivors. We call that journey mapping. Okay? What happened clinically? That is what you want. Yeah? And it's a life trajectory of the harm, and looking at where exactly can we do better? What were the failures in this system? Yeah? And as you can see here, this is Alejandra. Alejandra is the first of these 4 patients. She underwent a cesarean section with the spinal anesthesia in September 22. She experienced a sharp pain, but that can happen during the insertion of a needle. Yeah, and then progressively had headaches, fever, neck pain, light, sound sensitivity, all markers of meningitis. Okay. Repeated evaluations, but no diagnosis was made. Clinicians minimized the symptoms and even said it's postpartum depression. And that happens so often. If we cannot explain it, then we say it's something in the head, depression. And that's a pity. And then she learned, she learned about the outbreak through public news, more than through the doctors. Not very good from us, I guess. Yeah? The treatment involved prolonged hospitalization, repeated lumbar punctures, adverse medication effects, persistent long-term neurological symptoms. You will see it's devastating to hear the history of these kind of cases. I'm going to put this in a little bit bigger. This is the story. You see the dates on the bottom. So she delivers a baby in September with a C-section, private hospital in Mexico. Spinal anesthesia causes sharp pain. She is discharged after 2 days, nothing wrong, yeah, no complications, staff was limited due to a holiday. That's the first system problem, you understand? Of course, people need to go on holidays, we do understand that, but it can be an additional factor. She develops, you see, 4 days later, she develops headaches, high blood pressure, medications don't relieve, fentanyl, opiates don't help her at all. The symptoms worse a few days later with more neck pain, fever, back pain, light and sound sensitivity. And then she receives 5 days of injection, but no diagnostic well done. No diagnosis well done. Okay? Told postpartum depression. Very odd. We are now 14 days later. She sees a neurosurgeon. She is diagnosed with vascular headaches. Vascular headaches. MRI of the scan is normal. Yeah, the problem is not here, the problem is here. Understand? We should have done an MRI of the spine. The MRI is inconclusive, pain persists, no diagnosis, no medication given. We are now October. She continues to have medication, but she is unable to care for our baby, emotional distress, and then she learns, you see, we are now 6 weeks later, she learns from the news about meningitis outbreaks and recognizes her own symptoms and her own situation. And she goes to the department, and she's not admitted because she's breastfeeding. Then we are now more than 2 months later, 10 weeks later, she is admitted to the emergency department, and now the first time somebody took a spinal tap to examine the cerebrospinal fluids and confirms the fungal meningitis. They had already, in the public awareness of this problem. They start antifungal medication, but now she experienced chest pain and the dose was reduced. You see the side effects of the antifungals can cause also problems. She's moved to another room with other infected patients and learn more from the patients than from the doctors. She received 6 lumbar punctures, experienced facial numbness, dizziness, balance issues, signs of waiver for the treatment, and then she is still weak. She is told that the fungus could stay in her body for the rest of her life. It's not going away anymore. Okay? So if your immune system is suppressed, you will get a flare-up of the fungal meningitis, which is devastating. She continues to be an outpatient with checkups and still suffers from vision issues, fatigue, brain fog, returns to the hospital for follow-up imaging, told the inflammatory remains but no active infection, and she still experienced, we are now, you see 2022, we are now 2024, she still experienced migraines, memory deficits, dizziness, and told that the symptoms might be permanent. So isn't that devastating? This single case of a cesarean delivery under spinal anesthesia. Now this is patient number 2 of the 4. She received spinal anesthesia for a cesarean in October, developed chills, headaches, light sensitivity, vomiting, visual symptoms after discharge, hospitalized, major deterioration before conclusive diagnosis, experienced coma, seizures, neurosurgery, strokes, prolonged unconsciousness, weight loss, complications, and we are now more than 1.5 years later. And look what happens. So October 2022, the cesarean birth with isobaric bupivacaine spinal anesthesia. 4 days later, she experienced headaches, chills, sensitivity to light, goes to a gynecologist, and obviously he said that's postnatal depression, give some painkillers, and that's it. But that's the gynecologist. You cannot blame him for not knowing meningitis. We are now 18 days later. She starts vomiting, have visual alteration, all kinds of symptoms of meningitis. They do a lumbar puncture test for meningitis and immediately admitted to the ICU because the lumbar puncture are dark and muddy, the typical fungal meningitis lumbar puncture. The anesthesiologist informs Dina, the patient, that there's an outbreak of bacterial fungus. It's not correct, of course. The bacterial fungus is not a bacteria. Okay? And that's affecting her, and you see all kinds of symptoms going to the intensive care, to another clinic, becomes comatose, which lasted 5 days. And 4 days later, she was told she has that fusarium infection. Received then the first dose, amphotericin B, liposomal, and then she gets the shock and a heart attack. See the consequences? Yeah? And she recovers from it, but yeah, with lots of medication. She spent 6 weeks in the hospital in a state of coma. She was 6 weeks in coma and then experienced hallucination and all kinds of post-mental issues. She wakes up and the neurosurgery was done because she had an hydrocephalus now developed in her brain. She loses about 35 kilograms, and she was probably 65, has influenza infection, COVID infection, you name it, all on top of that. And then 2 strokes, all as a complication. She undergoes brain surgery, and an aneurysm at 5 centimeters was removed. Then she puts on platelet therapy because she was bleeding from a femoral artery continuously. So you see one after the other. Then she begins to be affected by pulmonary edema. She had to be treated for that as well. And amphotericin was given continuously, antifungal treatment, and she was told that the fungus would not disappear. It will stay in her body. If immune depression will be there, she can have a flare-up of her fungal meningitis. We are now 1.5 years later. Yeah, I've gone. Dina remains stable, waiting for the next cycle of meningitis, which can occur at any time. You see, devastating story. The third patient, Esmeralda, again spinal anesthesia, and gets postoperative nausea and vomiting within hours, persistent severe headaches, photophobia, and initial symptoms were interpreted as expected side effects of anesthesia. Yeah. But anyway, readmission, lumbar puncture, after prolonged and uncertain diagnostic course, where she ended up with a treatment with major side effects of the treatment itself, with lots of recurrent hospitalization. 2 years later, she still has chronic symptoms. And again, the story, you see, October 2022, in the hospital, spinal anesthesia, nausea and vomiting. You see the side effects in the recovery room, headaches, migraine, would not stop with any medication, and she's extremely sensitive to light. Condition worsens, vomiting. The doctor performs a lumbar puncture. The first result of the test is negative, but the day after it was positive. She is frightened. 4 out of women who had fungal meningitis have passed away. So 80% passed away in those early days. Yeah. The treatment of meningitis begins, and the right side of the body becomes paralyzed. Yeah. The whole right side becomes paralyzed after receiving that amphotericin medication. You see, she stops it after 2 weeks, but because of all the allergic reaction, but she needed it, of course. As several lumbar punctures, discharged from the hospital, she is told that her condition could worsen any time if she has an immune deficiency. And she had also a bacterial meningitis in the stomach. Same bacterial meningitis in the stomach, which caused her a lot of discomfort. She has been in the hospitals on several occasions with on average 2 weeks stay in the hospital. 2 years later, Esmeralda still experiences these symptoms like bone pain, intense migration, and dizziness, etc. Okay, and then you see these cases as across the case, the patient described a sterile breakdown. No information was given by the doctors. They had to learn it from other people. Okay, initially they were normal, and it was misinterpreted by doctors. I can imagine, because this was new, that it was not always that easy. Communication lacks, incomplete explanation about the diagnosis, the treatment, what to expect from the future. Fragmented care trajectory. So those patients really give you a clear idea of what kind of horrible things that can happen with them during these kind of. So the system failures, the process failures, and outcomes can all be dependent on these things. So for that reason, make sure that you do not blame anybody. It doesn't help anybody. Okay? So it's not a doctor, it's not a nurse, it's not the administrators. We have to take care of patients. We are the vulnerable people because they can sue us, they can do whatever. The administrators often use the finger point blame technique. Okay? So, and then the regulatory levels, the Department of Medicine in a country, so they too have to do their job. Each and every one has to do their job, even the patient. Okay, so human factors, that is what is causing all these troubles. And that needs to be, make sure that we understand that. Safety system design begins with understanding the patient is a central core figure. We have to do whatever we can to provide effective and safe, in all situations, anesthesia. Okay, it's not only the anesthesiologist, it's the whole care team. The doctor, the surgeon, the nurse, even the cleaning people in the operating theater are important. You understand? And then the organization and the wider environment is important. So why is this matter beyond this outbreak? This is a beautiful example of how things can go wrong in a hospital. This happened in Mexico, far away from us. But suppose tomorrow it would happen here in this hospital. How would we react? And I think my lecture is here to give a little bit of reflection time, so that you can take home, if there's a significant incident, make sure not to use the blame culture, but use the just culture, and try to find out what went wrong. And in that whole system, many things can go wrong. That is what we call journey mapping. Okay? So journey mapping reveals how survivors experience the outbreak of a sequence of missed signals, delayed responses, fragmentary care, and the patients, they tell us exact what they feel. The narrative exposed hazards that traditional clinic review alone may not see at all. The Durango outbreak offered a powerful case study in how weak systems transform routine care into a catastrophic event. And centering the patient voices can strengthen investigation, redesign, and prevention in healthcare system worldwide. Thank you for your attention.
Dennis, currently I'm in my first clinical year in medical school. So, first of all, I'd like to thank you for the opportunity for this. And regarding the the safety, I'd like to ask, like, considering both safety and accessibility, like, how do you think should guidelines be different in between high resource settings and low resource settings? Like, for example, in terms of what you explained about the experiences in Mexico with the meningitis, like the usage of single-use ampoules and multi-dose ampoules. Like, in terms of guidelines that may explain about those kind of procedures, like, do you think it should be different in both high and low resource settings? Maybe that's all for me. Thank you. I appreciate it.
Thank you. If I understand your question correctly, is why are there differences in these guidelines? Why do people not adhere to guidelines? Is that correct? Yeah. Well, I just recently wrote the guidelines for the worldwide use of videolaryngoscopy. And it's not that easy to write guidelines, because guidelines are only effective if they are supported by a large group of colleagues of us. Okay? What is a guideline if I write a guideline and I'm the only one who's following the guideline? That's not a guideline. But a guideline is something that is very important, especially for young doctors, yeah, because they need to start from somewhere. Okay? And if you have a guideline on neuraxial anesthesia, spinal anesthesia, epidural anesthesia, or airway management, the one I wrote just recently in the European Journal of Anaesthesiology about videolaryngoscopy, the worldwide default technique used in the future of airway management. And you need a large group, preferably from all over the world, many countries, and really leaders in specific areas, like regional anesthesia, airway management, and then you come with guidelines. But guidelines are just to help you, to guide you. They are not legally, in the fact, they are not legally bound. If I'm an anesthesiologist for 40 years, yeah, or if you're a staff member for 20 years, guidelines are good, but it is like work as done versus work as imagined. Work as imagined, that's the textbook, okay? That's the guideline. It should be done according to the textbook, in ideal circumstances, with an ideal patient, ideal support team, ideal anesthesiologist, ideal whatever. That is the guideline, okay? So we all work towards that idea. But in real life practice, sometimes the guideline needs to be bypassed because maybe I have to administer more anesthetics in order to do my airway management. You understand? Sometimes I need to adjust to that particular patient situation. Sometimes I need to give more, sometimes I need to give less. So it's not, if the guideline says Propofol 2 to 2.5 milligrams per kilogram. That is a guideline to help understand those who have to start in a specific discipline with what is the doses I need to give to the patient, what is normal. But the anesthesiologist in theater will say, no, that's a morbid obese patient, BMI of 60, yeah? Or that is a patient that has really very muscular patient, yeah? There's a difference, you understand? The patient, that evaluation of the patient by the anesthesiologist, that is the determinant to make sure what is the doses, what I'm going to give to this particular patient. So it's an individual treatment each and every time, but the guideline is there to help the younger doctors to understand what exactly I need to do. It is not legally bound. It is not like a traffic light. You are not allowed to go through red light, okay? It's not green or red. That's not a guideline. A guideline is to help us. Yeah? It's not that it has legal implications. I do not want guidelines to have legal implications. It is not made in stone. It's not a law, you understand? If I'm the anesthetist of that particular patient and I add on things, that's not listed in the guideline. Or I use a different doses that is not listed in the guidelines, I still am a capable anesthesiologist. You understand? And that is, guidelines helps. Yeah? But they should not be used as a legal case. Yeah? They should not blame you because you have done it a little bit different from the standard guidelines. There are about 3,000 guidelines. That's one of the other problems. 3,000 guidelines. Who is capable of having all the knowledge of all these guidelines? You see, it is helping us, but it is overwhelming, like the rest of medicine. You know that medicine knowledge doubles every 72 days? Who is capable of learning in 72 days all the new stuff? That's impossible. In 1950s, it took 50 years to double the knowledge in medicine, 1950, 75 years ago. Nowadays, it takes 72 days to double knowledge. And look at anesthesia. The knowledge in anesthesia is going very fast. The number of publications in anesthesia is going very fast. Nobody of us is capable of reading all the anesthesia publications. That's impossible. Yeah? So for that reason, guidelines are good because they are summarizing how we treat patients in 2026. But maybe in 5 years, these guidelines have to be adjusted. Because, look at my first lectures, the Propofol no longer are going to be used. Maybe. I think so. Yeah, and that it will be Ciprofol. So the guidelines have to be adjusted each and every time. So it's not made in stone. It's a flexible thing. That is a guideline. Does that give you an answer? Okay, my pleasure. Just repeat it once more. Okay. What do we see most as accidents? It is variant. Right? It varies depending on what you're doing. If you're an anesthesiologist covering the whole range of surgeries, yeah. If you're in thoracic surgery, you have certain problems. If you're in obstetric anesthesia, you have certain problems. If you're in pediatric anesthesia, you have certain problems. In intensive care, it depends on what you are doing. One of the things is airway management. Airway management, say 50 years ago, quite a number of patients died because of intubation into the esophagus. Yeah? So that is a clear thing. If we administer anesthesia, and I was talking in my first lectures about post-induction hypotension, but we know post-induction hypotension can occur almost in every patient. In every induction of anesthesia, we have post-induction hypotension to a certain level. That doesn't mean that we are doing something wrong. No. What we do, we bring the patient asleep, okay, and give them a certain level of depth of anesthesia. That is what we are doing. But in fact, by doing that, we are always overkilling. We are not giving the right amount because we don't know. We can't measure the depth of anesthesia. So you give always a little bit too much. That's the first thing that's happening. Yeah? We always give a little bit of overkill, too much, because not giving enough is even worse, because the patient may have awareness and recall during the operation and after the operation. And quite often in the past they said, oh, no, you were dreaming that. No. The patient can really understand sometimes the hearing is the last thing that disappears. Well, they can understand something is going wrong, and they can even formulate what you were discussing. And last week I saw in anesthesiology news that the patient was awarded, I can't remember how much, but I think $500,000 because he could recall that the doctor and the nurse were talking, and she was rather obese, and they were giving negative comments about her obesity. And that was enough to go to court, and the doctor was blamed for it and had to pay $500,000. In the United States is always these big money things. It will not happen here, I guess. But you do understand it is possible that if you don't give enough doses of a certain induction patient, that patient may have awareness and recall. Okay? I wrote an article a long time ago about awareness and recall and how to prevent it. And one of the ways was, for instance, adding nitrous oxide. But nowadays, nitrous oxide for the environment is not so well appreciated anymore, so we have to find other ways. Continuous infusions, TIVA, that kind of things with Propofol certainly will help prevent these from happening. But you see, we bring the patient, we give them a sedative or anesthesia, a bit more, yeah, that is what we want to do. But we always overkill because we want to be absolutely sure that what we are doing is the right job. Because you do not want to have awareness and recall. That is important. Was there any other question? No, there's a question. Yeah, it's well known that if you use a vial, big vial on many patients, that's no longer allowed in virtually all the countries in the world. I think Mexico was one of the last. Yeah? So that should not be done. Never use multiple vials for different patients.
Is it applicable same like the infection for the infections if we use the syringe?
Yes.
Is it the same?
Yeah, but that, for instance, for Propofol, it's not allowed to prepare your syringe and leave them, yeah, in the preoperative table or wherever you want to have it. And you, for instance, you have a big bottle and you have 5, 6 syringes. Don't leave them there because, well, infection may go up very fast with Propofol. There's the X substance in the Propofol that can result in very quick infections. So never do that. Especially, I've seen anesthesiologists who had a whole series of patients to do the whole day, and they prepared in the morning all the syringes. They were sitting there 6, 8, 10 hours. That's not good practice. It should not be done. Okay?
Thank you.
So I produced 8 standard textbooks, which you may have to learn. I produced about 550 scientific articles, and one of them is this one here. Yeah. So airway management is the core thing that we need to do. Anesthesiologists are the experts in airway management, and that's good. At least we got that recognition from outside the anesthesia department that surgeons, but also cardiologists, you name it, all the other disciplines, they consider us as the airway specialists. Because sometimes there can be a crisis. And if you cannot help a patient to get a good airway safe in situ, then we have a problem. Yeah? And we all know that, for instance, with Propofol, we have post-induction hypotension. But we all can manage that very easily. We give fluids, we give vasoconstrictors, etc. Yeah? That is what we are doing. But with airway management, it needs to be correct. It needs to be correct now, not in half an hour. You understand? And for that reason, I got a prize, I can't remember exactly the year, but about 20 years ago in Europe for visualizing in anesthesia. I always try to visualize. And my workshop is one of them. I worked in Eindhoven, the Netherlands, which is the city of Philips. You know, Philips, the manufacturer, TVs, CT scans, MRIs, you name it, all these medical devices. They were also the first, the CD was also invented by Philips. Very big company, 85,000 people were working there. And I was the professor of anesthesia, intensive care and pain therapy in Eindhoven. So a long time ago, before I moved to Australia, Brisbane, where they asked me to set up an academic department of anesthesia. But while in Eindhoven, I had very good connection with Philips. And I could use these high-end up ultrasound machines so that I could visualize each and every nerve in the body. Very high-end, very expensive ones, but thanks to my good relationship, I could use them everywhere. And I see the posters are still up. There should be 4 posters. Are they somewhere else? Okay, doesn't matter. I'll come to that later on. So I had lots of opportunities in my life to do that. I also worked hard on videolaryngoscopy. I was one of the founders of videolaryngoscopy. Also the videolaryngeal mask airways. I'll come to that in a moment. Yeah, because I wanted to visualize things. So ultrasound, that's the posters for instance, but visualizing the airway, that was another of my things. Okay? So, and you want to have good pictures, and I took hundreds and hundreds of these pictures, using, for instance, a CMAC videolaryngoscope. You can use these pictures, and you will see them everywhere. If you look up my vision article in Anesthesia Analgesia for how to do airway management in 2050, so 25 years from now. You will see lots of these pictures. Now, let me go to the presentation. Okay, this is my university. Okay, this is the first generation laryngeal mask. Just a tube with a cuff, and that's it, nothing else. Now, the inventor of the laryngeal mask is Archie Brain, and Archie Brain also worked in my hospital in the Netherlands, and for that reason I got interested in these laryngeal masks. These are second generation laryngeal masks, a bit odd, these ones here, but you see, now we have a double thing. This is a channel that goes all the way into the esophagus. You can have access to the gastric or to the stomach. See that? And you see different of these branches. Okay. Then I came up with a new idea, my vision of the case for a third generation supraglottic airway device facilitating direct vision placement. I thought, okay, I've done a lot of work on videolaryngoscopy, and I thought if we have the laryngeal mask airways also with a videoscope, then I can see how it sits. Because it was demonstrated over and over again that 50 to 80% of all laryngeal mask airways were positioned in the hypopharynx in a suboptimal way. Suboptimal way, I will come to that in a moment, that means that you can lose the airway. That's not what you want. You do not want to lose the airway in a mid-surgical case. You understand? So, based on this vision, yeah, the manufacturing industry produced a number of these videolaryngeal mask airways. That is, for instance, 2 of these videolaryngeal mask airways, the VLM, and this is the SAFE LM. You see images, you clearly can see the glottics, yeah, and that gives you the right impression, okay, this is now clear, and if I want to do an intubation, I can still do that. So, I produced features of the new vision incorporated third generation videolaryngeal mask airways. I did it with Professor Cat. Professor Cat will come and lecture here this coming week, okay, next week. So, these are, for instance, you see a video scope, you insert it into a special channel here, and it comes out here. See that? Okay, so this is the complete setup, but you can take them apart. This is a laryngeal mask, second generation, with a gastric tube coming out here, and a special open, this is for the ventilation, and a special opening that fits your video scope. So just a combination of an LMA and a video scope. And I can see inside into the hypopharynx all the way during the insertion. I can see how it sits in the hypopharynx and how it sits against the glottis. Okay, and you can do that the same with this device here. That's another LMA, but that depends on the manufacturer, of course. And you can insert that here inside, and it goes in here as well. So the oropharyngeal leak pressure was used as the gold standard to know whether an LMA was sitting correctly. Because that's really good. Well, we all were using 40 to 60 centimeters of water as the ideal standard. Because if you have a leak pressure, then you know something is wrong. And I'll come to that. Yeah? And the oropharyngeal leak pressure, ideal-wise, for the first generation was 20 centimeters, for the second generation 25 centimeters. And then you had to use fiber optic evaluation. You had to use a fiber optic scope, but that's very expensive. Just for a simple evaluation whether your device is sitting correctly. And this is what you can see with fiber optic scopes. You see the epiglottis is overlying, it's sitting into the bowel of the laryngeal mask, and sometimes it's even depressed, and that's not what you want. You do not want an epiglottis that is downfolded into the bowel of the device, because sometimes it's even completely obstructing the entrance to the trachea. That's not what you want. Okay, so oropharyngeal leak pressure, it has some values, and we published that in Acta Scandinavica. It has some values, but you need to know absolutely the position of the device. So we have blind insertion technique, and we have vision insertion technique. The blind insertion technique, null positioning 50 to 8%. That's a failed device. Nowhere in medicine, if you would say 50 to 80% is not correct, that would be acceptable. Why would it be acceptable in anesthesia then? Okay? And it was based on all kinds of imaging technique, MRI, CT scan, radiology, ultrasound, clinical research, fiber optic observation. So something was wrong. And I thought, now, if we can combine videolaryngoscopy, and I had a lot of experience and a lot of, I published about 150 articles solely on improvements in airway management. And I thought if we can combine those two, instead of blind, we vision guided, and I called it the insert, detect, correct as you go technique. Okay, so you put it in, and while you're inserting it, you see whether it's going the right way or the wrong way. And if it is the wrong way, you have these corrective maneuvers to bring it in correctly. That is what I want. So I produced an algorithm, and I wanted to go away from blind techniques. So vision guided, what we can see, we can do much better. And this is the insertion of a laryngeal mask. You put it in, deflated cuff, all the way down to the hard palate, and then it goes in there. Okay, see that going there. But look at the epiglottis. The author here did not know what to do with the epiglottis. You see that? It seems as it is behind the cuff. That's not correct. You see? No longer epiglottis. Where is it? It should sit on top of that here. So I forgot to do the right thing. So that is blind insertion, okay? And the epiglottis will end up in the bowel of the device quite often. So this is how it should be. This is your laryngeal mask airway, inflated cuff. This is the trachea. This is the esophagus. The distal part of the map of the LMA should sit and block the esophagus, while the proximal part, you see here, the epiglottis should sit on top of the device. And in fact, the ideal size can be evaluated if you see the tip of the epiglottis. So the epiglottis, the tip, should align with the proximal part of the cuff of the LMA, the inflated LMA cuff. That should be aligned. If it is too deep, then it means it's too small device. If it sits more here, then it means the device is too big. This is an ideal size for this particular patient. Okay, but how to find that out? Just by looking at it. Okay, but the device should not, the epiglottis should not sit into the bowel of the device, because then it is downfolded and even retroflected and blocking the entrance to the esophagus. Okay, this is what you can see here. You see, this is too big, the device. Too big the device. Normally this part and the proximal cuff, yeah, should be aligned. That's not the case here. And the epiglottis is now sitting in the bowel. See that? It's in the bowel. And sometimes it's completely downfolded. Completely downfolded. See, it sits in the bowel. See that here? Okay, so I came up with the idea we need to have a scoring system. How good do we see? Yeah? How good is that device sitting? And can we have an objective evaluation using, for instance, videolaryngoscopy? Because they are subjective tests, and perhaps they are using it as well. The self-inflating bulb technique, the light one test, the insufflation test, you name it, the bubble test, all kinds of subjective tests. It's never as good as if it is a visual test. Okay? So 3 maneuvers for any clinical situation was published by Jangan Verghese, very big name in airway management, but all based on subjective tests. For that reason, I think it's not good. You see all these tests here. Yeah? They all have disadvantages, and they are not as good as a visual test. So I came up with the idea of having a look inside through the tube of the laryngeal mask airway, and looking at what we can see here of the glottis. Okay, so we have the first seal. The first seal is this one here. The second seal is this one. And that needs to be adequate. So the first seal, make sure that we can have a ventilation. The second seal, if there's any stomach fluid coming up, yeah, it should not go into the trachea. That is what we want. Okay? And the optimal fit for the supraglottic airway devices, if they sit in the correct way, as you see here and here. Yeah, and this is a radiography. Yeah, and you see, this is a perfect sitting element. See, this is the tip of the epiglottis, and that's aligned with the proximal cuff of the LMA with an inflated cuff. That is how it should be. Okay, so the tip of the distal cuff blocks the esophageal sphincter. So this one sits here. That's the second seal. And the distal cuff occupies the hypopharynx. You see, the distal cuff occupies the hypopharynx here. We have the first seal, this one. The second seal, this one. Okay? And the epiglottis should be flattened between the proximal cuff and the tongue. So this is the tongue here, this is the cuff, and this is the epiglottis. It should sit between those two. And then this is anatomically, and functionally, there should be a functional barrier. There should be no fluid coming from here going into the trachea. Okay? Adequate gas exchange. When we ventilate the lungs, that should be adequate. Okay? But depending on the position of this LMA, you can have an easy gas exchange or you can have a difficult one. And no trauma. There should be no trauma. Patients with an incorrectly positioned LMA have sore throats afterward. They have pain. Yeah? That should not be the case. Okay, so these are perfect positioned LMA. This is an eye gel. This is a classic LMA. and this is a supreme, LMA supreme. And you see, correct alignment, and a correct alignment. See that? That is perfect positioning. Okay, the alignment here should be clear. What happens if you have misalignment? If this is inflated too much, yeah? Then you see the tendency that it is coming out of its position. And then you see what can happen. This is the ideal situation. You see with an ICL, you don't have a cuff to inflate. So sometimes there's still a gap. Still a gap, that means stomach fluid may come up and be aspirated into the trachea. This is sitting too deep. It should sit like that, aligned, but here there's no alignment anymore. This is too deep. The device is too small. And this is too big, as you can see. Too big, and that risks dislocation. And then you don't have any airway. So the first seal is important. This is not a good seal. This is a leak. This is not a good seal. You see, these PVC LMAs, they can have these foldings, creating gaps. You see the creating gaps? So there's not a good seal. Okay? And LMAs should be inserted using the hard pallet at the back, and then it should sit in here. And the epiglottis should sit on the outside. Okay, this is a spontaneous breathing patient you see here, and the tongue, yeah, sorry, the tongue here, yeah, there's a gap. That's how we breathe. We breathe in and out. We do that all the time. So this is a spontaneous breathing patient. Look at here. These are the tonsils. Now look very carefully what will happen with the tonsils if we put the patient to sleep. Yeah? The tongue relaxes and blocks the entrance to the trachea and the esophagus. See that? That is what's happening all the time. So if we do a blind insertion, yeah, it should be the ideal size by aligning the tip of the epiglottis with the proximal cuff of an inflated cuff. This is too big. And then the epiglottis sits into the device. Yeah? And you see that here as well. This is too deep. Yeah? That means that size is too small. Size too big, size too small. You understand? It needs to be aligned, those two. Some of my pictures were put at the British Journal of Anaesthesia, even on the cover. So only 12 people get their publications on the cover every year. So this was one of mine. So mild positional supraglottic airway devices. So we published this in I'm going backwards, sorry. You see here all kinds of things. This is in a model that we produced just to demonstrate how it was, and this is in patients. So this is in patients, this is in a model, you see, correct? This is too small, this is too big, and this is even with the epiglottic downfall completely, and that results in a complete obstruction, okay? You have to take it out and restart. So this is the ideal situation, alignment here. You see the gap here. You see this is too deep, this is too superficial. Yeah, and sometimes you have also these bars, the LMA bars. You see that here? The aim is to protect the epiglottis from falling out. But in fact, they have no role whatsoever. We demonstrated that in several studies. You should not use LMAs with bars. LMAs with bars, I don't think you can even buy them anymore. You see the epiglottis, sometimes it keeps them falling off. Okay, this is with foldings in the plastic, the PVC. So you see that? It's creating a gap, same gap here. Sometimes these LMAs are folding over backwards. Can you see that? Folding over backwards, that means that the opening to the trachea is blocked. That's not a good situation. And sometimes, and I could demonstrate that, you see here, that's the tip of the LMA, sits in between the vocal cords. That should not be the case. It should not sit in the vocal cords. It should sit on the outside of the vocal cord. And you can see the epiglottic downfolding here. And sometimes I even see the epiglottic double folding. See, all kinds of images which make sure that vision-guided insertion is much more important. So with fiber optic evaluation, you could see here these mask aperture bars. You see here the vocal cords. You can see here the vocal cords, and you can see here the vocal cords. Without these mask aperture bars, because these mask aperture bars sometimes they make it more difficult, as you can see here. Now the epiglottis is downfolding, and it's going to obstruct completely the entrance to the trachea. So that is what we see. So too big, yeah, and this is downfolding, completely downfolding of the technique of the epiglottis. See that? And sometimes these epiglottis can even be trapped by the mask aperture bar. You see the epiglottis is now protruding through the mask aperture bars and is completely obstructing the airway. And this is a very bad situation, obviously. And here you see the epiglottis. Yeah, these are the mask aperture bars. But what is the function? They have no function whatsoever. They make it only more problematic. So don't use them. You see, these are the mask aperture bars. Epiglottis protrudes between those mask aperture bars, and that will traumatize the epiglottis, and for that reason you will have a sore throat in the post-operative period. See that? Yeah, it's all these kind of things. They even made an epiglottis elevator bar, but again I could demonstrate it's absolutely rubbish, because the entrance to the trachea is completely blocked by that epiglottic elevator bar. Yeah, here another one and another one. So all devastating situations where you can see these things. Yeah. I have hundreds and hundreds of these pictures. It happens with all kinds of LMA brands, so it's not specifically to one particular brand. But you see the LMAs, it can sit correctly, but sometimes it does not sit correctly, and with the epiglottis inside the bowel or creating a gap or too big. You see, even the LMA, even the eye gel, they pretend of having a very good blind insertion success rate, but that's not the case. You see the eye gel, the LMA Supreme, all kinds of problems, LMA Protector, all of them can have significant side effects. Jaw lift and chin lift and jaw thrust can help you to create that gap behind in the hypopharynx, make it easier to insert. So this is the jaw lift done in a particular patient, and you see you create the gap to insert it. So these are a few of these maneuvers. These is the retroflexion, which is obviously not good because you don't have airway access. This is with the tip in between. You see the vocal cords, and the tip sits now into the vocal cords. That is what's happening here in those cases. Yeah. The tip of the epiglottis and the proximal cuff, that is, I have alluded to that. Cuff hypoinflation, it needs to be checked between 40 and 60 centimeters of water. Okay, that is important. Oops. Yeah. The risk of too much inflation, if you inflate it above 60 centimeters of water, is dislocation, malalignments, air leaks, all kinds of problems, but the risk of losing the airway, that's important. Epiglottis folding double. Well, the epiglottis should sit on the outside of the device, not folding double. See that? Yeah? That's creating all kinds of airway problems. Cuff foldings here, results in leak, and it's always in PVC LMAs, not in silicone ones. So we came with a grading system. We said this is a perfect one. So the alignment between the tip of the epiglottis and the proximal cuff, that is a perfect seated mask airway. Epiglottic resting on the outside of the device. We see a normal capnogram, good air entry, excellent gas exchange, and the oropharyngeal leak pressure should be 25 or more. The intercuff pressure between 40 and 60 centimeters of water, and that results you in the saturations 95 or more. Proceed with anesthesia and surgery, grade 1, ideal situation, you've done a great job. Okay? But what happens if it is suboptimal? A marginally positioned airway, adjust maneuvers, like this one. Airway leaks, abnormal capnograms, impaired gas exchange, lower values of the oropharyngeal leak pressure, cuff pressure. Perhaps you have to do something about it. Now I know even a suboptimal positioned LMA sometimes functions adequately. But the ones you cannot accept, that's a grade 3. These are clinically unacceptable. If your distal cuff sits between the vocal cords, you will have an enormous leak. You will not have a cuff, you will not have an intracuff pressure at all. Okay? So that is these bad things. You need to adjust that before you start the surgery. Very low values of oropharyngeal leak pressure, intracuff pressure, and low saturation. You need to have these adjustable maneuvers and do not accept it. Now, I'm not going too deep into that. You can read it in the British Journal of Anaesthesia, where I have designed, for instance, this is the optimal position. This is examples of suboptimal and what you need to do, the corrective maneuvers. Okay? So make sure that you know exactly how to do that. So failed supraglottic airway, an algorithm, how to modify a suboptimally placed LMA into a correct one using videolaryngoscopy. Okay? Vision-guided placement of supraglottic airway device prevents airway obstruction, and we did a prospective for audit. And in fact, by doing that, I could demonstrate that it is really absolutely perfect to provide good seals with no leaks, as you can see in here. So laryngeal mask airways, ideal feature is use the second generation, forget about the first generation LMAs, use an optimal position of the airway, and you can use it as an intubation conduit. And in fact, the difficult airway societies, they tell you if you can't intubate the patient, you need extra equipment, use an LMAC for a time out position. This is absolutely vital. Secondary is the size, but is still important, the cuff pressure and the oropharyngeal leak pressure. So we did a study comparing LMAs Supreme with LMAs Protector. Remember that 50 to 80% of all LMAs were positioned suboptimal. Well, as you can see here, I had a grade 1, 96% and 94%. So 95% of all my cases were in the optimal position. And very few were in a grade 2 and none were in a grade 3 position. So it is feasible to do it using videolaryngoscopy. That was the time before I developed the videolaryngeal mask airway. Okay? So why going blind if you can see with the supraglottic airway devices, with malpositioning of these devices, malpositioning of tubes, NIM tubes, yeah, nasogastric tubes, oropharyngeal airways, orogastric tubes, temperature probes. You have to visualize these things. It makes your life so much easier if you do. So then I came up with my vision of the third generation videolaryngeal mask airways. We were using these kind of things. They are produced in big companies nowadays. Well, there are lots of features. Please read them yourself if you want to compare new devices. Okay, with a cleaning line, with a clear vision, as you can see in here. We used these were the very first uses of videolaryngeal mask airways. And we were looking at the monitor here how to insert it. It's not an optimal vision, but anyway, that this is how we were using it. So you can even use it on your mobile phone nowadays. There are all kinds of advantages. Yeah, so this is what we are doing. Okay, these are a few of these cases. And all the technical items you can use images capture, display screen, with USB ports, you can record it, you name it. This is the kind of images that you have, and you can use it also to insert a tracheal tube into the trachea via the laryngeal mask. So lots of advantages. When you see the videoscope that you can insert it, brings it in, but it's flexible. You see it can flexible. You can look around what you want to do. See that here? So we did mannequin studies, we did human studies. There were some original devices like the ILMA or the Total Track, but they were designed to insert a tube into the trachea. The videolaryngeal mask airways that we designed are in fact to insert a laryngeal mask airway in the correct position. And secondary, it helps us to insert a tube. Okay? So that is what we are doing. So vision-guided insertion of supraglottic airway devices, I think, is the final solution to avoid malpositioning. I also produced a new scoring system. I'm not going too deep in that because it takes a whole lecture on itself, but you can do all kinds of scoring systems. And then I produced last year supraglottic airway devices, present state and outlook for 2050. So my vision, how it will be in 25 years from now. So with lots of infographics, as you can see. Thank you for your attention. Look, there are many scores used in airway management. Yeah? Cormac-Lehane is one of them. The Malampati is another one. By the way, Malampati died just a couple of months ago. Professor Gatz will lecture next week on that topic. So, but these are all evaluations, but not optimal evaluations. Yeah, it depends on the size of the tongue, for instance, whether your Malampati will be a high score or a low score. The Cormac-Lehane, it gives you an idea, a classification, how difficult it will be. Yeah? So it gives us information about the airway management, how difficult it will be. But wouldn't it be better to have an ideal device in your hands so that you can manipulate the laryngeal mask airway, the tube, whatever. And even in the most difficult cases, don't have it with me today, but even if you have a videolaryngoscope, good videolaryngoscope, if you still can't see anything, there are ways to circumvent and do the intubation using, for instance, a bond fizz. You know a bond fizz? It's an optiscope. Okay? If you look up my name and bond fizz, you will find a few of these publications as well. Okay? So even in the most difficult case, if you don't see anything, I call McLean 4. Yeah? Even with the best techniques, videolaryngoscopy, yeah? use your videolaryngoscope and the bond fizz, and you can intubate the patient. So you want to avoid epiglottic trauma, okay? Yeah. By doing that, make sure that there's a chin lift or jaw thrust, okay? So opening the back space between the base of the tongue and the posterior pharyngeal wall. You understand? Like we are breathing on our own. If we are relaxed because of a sedation, anesthesia, the tongue falls backwards. So the only thing that you can do is just chin lift and jaw thrust to make that opening. Otherwise, the LMA cannot go behind the tongue. Understand? So that is one way of avoiding trauma. But the trauma itself is caused by the fact that the epiglottis is downfolded, it's double folded, yeah, and not in the correct position. I hope that I've made it clear enough with all the images that I present. Please look up on my article in the British Journal of Anaesthesia about what to do with failures and the corrective maneuvers, because it gives you a little bit of a guideline what to do next. And in fact, it doesn't help you by pulling out the LMA. No, you have to see what exactly is the problem and adjust it accordingly. That is the main reason what you need to do. And if you see that the size of the device is too small or too big, you have to adjust that. If you see that you're folding backwards with the LMA, then you need to withdraw it a little bit and slide it in. All kinds of things, but please look at those features in the British Journal of Anaesthesia. I hope it was useful.
Okay, we will now move on the workshop session, where we will have the opportunity to translate the concept into the hands-on practice. Today workshop will focus on ultrasound-guided regional anesthesia blocks on the upper and lower extremities. We are honored to have Professor André van Zundert guiding us through this session. Professor, the time is yours.
Thank you very much for coming to this workshop this afternoon. It's always good to have, besides theory, also a little bit of practice, isn't it? So thank you for the opportunity to demonstrate the use of ultrasound, because it's very important that we can visualize things. I told you already this morning, visualization helps a lot to improve anesthesia. You've seen it in airway management, you've seen it in visual anesthesia, but these kinds of blocks we can visualize. The thing is that you need to learn to work with your own equipment. For me, it's the first time I'm using this equipment. It's always a little bit difficult to understand very well all the knobology. So somebody needs to teach you about the knobology. That's very important, that you know each and every button. Second is, it's important that you know how to use the ultrasound. Now, for not too deep things, for very deep ones, we are using the curved one. See that? The curved one. But not too deep, that means if I want to go into the abdomen, then I use the curved ones. But if I just want to do it for regional anesthesia blocks, then the straight one. That's the better one. Okay? Because I do not want to go too deep, and this one will just give me the anatomy of the superficial areas. Understand? So use this one all the time. There's maybe a third one. No, not here. But for instance, for finger, or for very, very tiny ones. Okay. So we are going to demonstrate it on the big board, but I hope that you, in little groups of 2 or 3 people, can practice as well. You need to do it not in a whole group like this, but just 2, 3 people, one teaching the other. Okay? It's absolutely it's absolutely essential that you practice a lot. You few of my structured approach. So with images, the images will explain or explained in detail what exactly we need to see. Although there is a variance in anatomy models. This model is different from another, from me, from you. So it is not a perfect textbook. As I told you before, the guidelines in the textbook tells you this is ideal. But what is ideal? Anatomy is not always ideal. We know there are deviations. Now the first thing to know is that you need to work with these guys. There's a little button here. See that? Little button? Okay. That needs to be on the, when you are going to use it, you need to know exactly where that button is. So if I'm going to use, and I try to be on the side of the patient so that I can see the face of the patient. It's important that I see the reaction of the patient, especially if I'm going to inject something, I want to see a reaction. Because if I don't see his reaction, how do I know whether I'm injecting, for instance, in the intravascular, or whether it's painful? So I do not want to stay there. I want to stay on the side. I want to face to face the patients so that I can see it all the time. Whatever block I'm doing, I want to see this face to face. Not going to stand over there. I know some anesthesiologists standing over there and do the block like that. That is not the way I want to do it in a perfect and safe manner. Second, you need to visualize things. So first of all, what we are going to do, you can also use this to visualize the airways. So make sure that the patient has enough of space. I'm going to lift this a little bit. This pillow should come a little bit on the side so that I have enough space here. If the pillow is too much in the middle, then I do not have enough space. Okay? Second thing is that little knob on that side, I can go immediately here. So now you have to tell a story. Can you tell me a little bit of a story? So sometimes you can see the vocal cords. See that? See it? Okay, that's good. Thank you. Okay, so that's one side. You go to the other side, you can see, what is this? What is this? We have a pointer. Can you give me a pointer, please? Can you have a look here? What is this? What is that? This is well known, huh? If I put a little bit of, you see immediately, it's pulsating. Pulsating, that's the carotid artery. Okay? Carotid artery, but what is this? This is the thyroid. Okay? So you can evaluate the thyroid, whether there's a tumor, you can actually see it. Okay? That's on that end. I can do it on this end as well. Okay, what do I see now? Take a deep breath. Okay, that's a deep breath. It's going to, okay, yeah, thank you. Now I'm going to push, and what you see the difference between that artery, sorry. So that's the artery, and you see the vein. Understand? And what's in between the jugular vein and the artery, carotid artery? Which nerve is there? The vagal nerve, vagus. Okay, that's over there. And there are little branches here and there, because this is the thyroid with very tiny arteries in there as well. Okay, it's overlying. This is the tract. Okay, so that is what you can see in here. So if you want to do a central line, then you bring it in like that. Okay, insertion of the center. Now, if you want to have a good look of the, you first look into the thorax. So look into the thorax. So it goes just above the clavicle, the collarbone, and look into the thorax. Okay, that is what you can see in here. Look into the thorax. Okay. You see the artery and the plexus is just next to it. Okay, plexus next to it. Then you go towards the ear. And you go towards the ear and you see the plexus here? It's not always easy to go immediately to an interscaline block. But if you look at first like this, so look into the thorax, and you see the artery, the plexus here. It's like a grapefruit, like grapes. See that? Okay, and then you slowly go in the direction of the ear. You see all the plexus here. See that? Cervical plexus here. That is C4, C5, C6, C7, C8. That's your cervical plexus. Okay. On this side, You have the anterior scale and this is the posterior scale sorry, the intermedius and the posterior scale. So it sits in between two scale muscles. Yeah? Very easy to recognize. If I go up a little bit, sometimes I can show it. Phrenic nerve, sometimes I can show it here. Phrenic nerve, just opposite the scalene anterior. I think it must be this one. Okay? So, if you want to do an operation on the shoulder, this is the way to do it. Okay? Interscalene block for shoulder surgery. If you don't need shoulder surgery, you need to have the arm, and you have to come down. Okay? Then a better way is to have it here. This is for the supraclavicular block. Supraclavicular block. The artery on the medial side, the plexus on the lateral side. Okay? Now I can do the whole arm. Anesthesia for the whole arm. And block the whole thing here. Okay? So that is supraclavicular. I can do infraclavicular. I take my hands. See, that is the thorax. The thorax, and I go all the way. This is outside the thorax. This is inside the thorax. So if I feel the acromioclavicular joint, this one here, I can go halfway and I can use my needle perpendicular to the skin and block the infraclavicular plexus. You understand? So make sure this is the thorax, that's intrathorax, and this is outside the thorax. So I can block this way. So I can block all the way from here to this end, to this area. Anywhere I can block the plexus. Okay? We call it interscalene, suprascalene, infraclavicular, axillary block. Yeah? But it's like a street. From this point onwards all the way to this point. Understand? Good. That is what we can do. So if we do it in, infraclavicular, it's easier to measure and do exactly on the midline from that point to that point here, the acromioclavicular joint and the incisura here, midways, and you can do the block here. Okay, because it's not always that easy. Okay, the plexus is around the artery. It's around the artery. Okay. Next phase. Yeah. We do the axillary block. Axillary block. The dot should be on the upper part. Okay. Now? Yeah, thanks. Okay, so you look into the axilla, okay, and you see it's okay. So you look into the axilla and you see a number of veins. There are usually 3 or 4 veins over there and 1 artery. Okay? See that here? So 1 artery and several veins usually are around. If you go a little bit higher, okay, you see the biceps here? Bicep, this is the triceps. Okay, there's 1 nerve. Do you know how it is called? Musculocutaneous nerve. Musculocutaneous nerve is going to innervate this part. Okay? This part. That's an important one, but you can move it around. You see, you can move it. See? Yeah? So you can move it. You have to block this one separately. If you have to do an operations on this side here, you have to block this separately, because otherwise it's not going to anesthetize, because this is a branch off immediately far higher up. Okay, so artery here, artery, you see veins. This is the median nerve. Median nerve. And in between the vein and the artery, you have the ulnar nerve, and this is the radial. So it's around the artery with 3 branches now. Median nerve, very high up. Between the artery and the vein, that's the ulnar nerve, and at the backside is the radial nerve. Try to understand the anatomy. Yeah, it's around the artery. See that? So you have to block these, whatever is necessary for this particular patient. This is the median nerve, the ulnar nerve between the 2 vessels, and then at the backside you have the radial nerve. You have to go specifically to the nerves that you want to block, okay, depending where exactly it is. Good. Now we can come to the ulnar nerve. You can block it here, not in the sulcus, but a little bit higher up. Not in the sulcus, but a little bit higher up. So I'll show you that. Okay, see the bone here. Okay. There is the nerve. See the nerve over there? That's the one. That's the ulnar nerve. Very superficial. See that? Over there. Okay, another one, very easy to do, is the median nerve. I'll just go here. And that's your median nerve. Oops. There. Yeah. That's the median nerve. Very easy. Just go like this, and you got it. Okay? Okay, see it's very, very clear. Huh? Okay, it's very distinguished. There are no arteries in the neighborhood, so that's very good. Very easy. If I go further down the road, then it starts to become very difficult. How many tendons do we have here? 9. 9 tendons. 9 tendons. Plus arteries, plus nerves. Makes it rather crowded. So if I do it this way, sorry, that becomes very difficult to distinguish. You understand? If I use my, there's that tiny, but now it's a very tiny one. Yeah, that's the artery. And the nerves are on the median side. So that's the radial artery. That's an ulnar artery, and this is the ulnar nerve. So the ulnar nerve, you have that little sesamoid bone. So sometimes if you have a little scar, and I've seen patients with 1 centimeter of a cut, 1 centimeter, and the ulnar nerve was over. Okay, so you can actually feel your artery, and on the medial side, that is the medial side, you will find the nerve. Very superficial, very tiny, so you only need to give maybe 2-3 centimeters of cc's of local anesthetics. No more than that. And the same on the other side, you have the radial, and radial artery. Go to the medial side of it to find it. Okay? So you see it already there. Okay, can you see it? Okay, and that's the nerve. Okay? You can go even a step further. Oops, sorry. And do blocks on the finger. But you normally use then the very tiny. Now this is too big. You understand? Probe can be very big. Okay? But you see a finger, and the nerves on both sides. Okay, a finger block is very easy. You just go on both sides here. Okay. So we have done already quite a number of blocks here. But there's one more, and that is the radial one. You see that here? In fact, it's very easy. Feel this part here, and you actually can feel your radial nerve. It hurts a little bit. So go a bit like this, over it. Like that. So, okay? Feel it like this. This is the exact place. You should be able to feel it yourself. Okay? If I use it with my probe here, there they are. See that? There are two nerves here, two radial nerves. One profunda, one superficial. That's this one. Very easy to block. You see, very superficial. It's, you see on the side, it's 1 to 1.5 centimeters. Okay? So it's actually here. So, what did we learn now? We learned that we can do supraclavicular blocks, very popular technique, the Kuhlenkampf technique. Yeah, we can use infraclavicular blocks, but usually it's a little bit more difficult because it's deeper, and already we have the branches. We can have the axillary blocks, the ulnar nerve block, the radial nerve blocks, and the medial nerve blocks. It's here. That one. So very easy to block that one. You actually can go in between those two tendons. You see two tendons here. The medial nerve sits in between those two tendons. Okay? But it's more difficult here than to do it here. Here there's no problem whatsoever, just go in the midline. Now it's important to know the anatomy. So we have C2, that is the sensitive area, C2, C3, C4, and this is C5, C6, C7, C8, T1, and T2. Can you remember? Okay. Where is C1? This is C2. Where is C1? does not exist. There's no sensory innervation of our skin for C1. It's just internal. So C2, C3, C4, C5, C6, the pump, C7, yeah, the middle finger, C8, T1, T2. Don't forget, it's very important because if patients are operated upon, you need to know exactly which nerves you need to freeze. Okay? So C2, C3, C4, C5, C6, C7, C8, C1, T1, T2. Now, that is sensory block, but how to evaluate the motor block? Because surgeons do not want patients to move. Okay, how can I evaluate my functions of the radial nerve, the middle nerve, the median nerve, and the ulnar nerve? How to do that? It's very simple. If you want to evaluate, ask the patient to do 1, 2, 3. Understand? If he still can do that, that means that your block is not satisfactory. Okay? Now, what is, if you have a block of your radial nerve, then the hand is like this. It can't move this anymore. It can't do this movement. Okay? What is it? The ulnar nerve, it can't do this anymore. With 2 fingers. And the median nerve, they can't do this anymore. Okay? But the important one is the radial one. Yeah? It needs to, like the dropping hand. Okay? Don't forget these take-home messages. Okay. I'm going to clean this a little bit. Okay. Yeah. Yeah, I think so. Drop it on the floor. Okay. That is for the upper extremity. Yeah. Okay. Ready? Okay, next thing is what we can do intercostal blocks. Now, this is a rib and another rib and another rib. We have plenty of ribs here. If you would block 6 ribs on this side, and there are 6 lower ribs on that side, you can do abdominal surgery. Yeah, 6 ribs here, 6 ribs here. You don't do that anymore because 6 times to do a block, that's painful for the patient. But it can be done. Yeah? So really, if it is a very difficult case and the patient cannot undergo general anesthesia, this would be a possibility. Another possibility, perhaps you know that, but I described the thoracic, segmental thoracic spinal anesthesia technique. I can do blocks just limited by this. Instead of a spinal, yeah, where you normally the whole limbs are anesthetized. That's not the case. I can do a block like this, just from here to here. You have to do, for instance, gallbladder surgery, stomach surgery, colon surgery, just by doing this here. And because the lower limb is unaffected, the blood pressure will not drop too much. It's one of the other techniques. Perhaps maybe next year lecture about this technique. Now, what can we do? Make sure that the point is pointing upwards. And if you look here, you see that? Okay. So, we have 2 ribs here. In between, you have the intercostal, external and internal. Okay? You have to, if these are 2 ribs here, you have to walk off the ribs till you drop. Not on top, not just at the bottom. The nerve is always at the bottom. Okay, so make sure that you walk over the rib till it goes back a little bit, and then do the injection. Just 2 mils of a local anesthetic, and that's enough. So that is what can be done. Okay, see that? It's very easy to do that. And this is already the pleura. So don't go too deep. So just walk off the rib. That's it. Here, that area. Okay, that's one of the things. Another thing is what you can do is who knows this one here? What is this? This is the umbilicus. Yeah? So this is the umbilicus. Just above the umbilicus, and what do we have here? And what do we have here? These are the rectus muscles. Rectus muscle. Okay? Now, just in the middle of the rectus muscle, here, we have a nerve. Innervating, for instance, the umbilicus. So if you have children to be operated around the umbilicus, that's a very easy to do block here. Because you see, this is all bowel content. Yeah, this is the peritoneum, and this is the fascias around the rectus muscle. You understand? So in between, you just need to go in between the two, inject some local anesthetic, and it will spread itself on both sides. That is what can be done. See that? Okay. So that is, you can do that anywhere. See that? You can do that anywhere under this. Yeah. From all the bladder all the way down to the subcostal area. We can go also on the side. Okay, we come from here, umbilical area, we go to the rectus, and if we go down, then we see 3 muscles here. You see 3 muscles? Obliquus external muscle, obliquus internal muscle, and this is the transversus muscle. See that? If I go a little bit down, okay, you see tiny nerves in here. In fact, there are 2 nerves in here. There are 2 nerves coming from the back. One is the hypogastric nerve, innervating this area, and one is the ilioinguinal. That's going into the inguinal area. Understand? So 2 nerves are coming from the back, ilio-hypogastric nerve and the ilioinguinal. Understand? So if you have to undergo inguinal hernia repair, that's a very good one to block. And it's very easy because okay, so you go to the side, you see the 3 muscles here, obliquus external, obliquus internal, and this is the transversus, and between the internal and the transversus you see the tiny little nerves. Okay, so you can do the injection, very simple. You come either from this side or from that side, and you manipulate your needle towards this nerve here. See that? And you block this whole area. Very useful in children, of course also for adults. You can do that on both sides. You can go to the other side. So obliquus external, obliquus internal, and then this is the transversus, and your nerve should be somewhere there. Okay, see that? Not too difficult, huh? Okay, good. That's the only big disadvantage. You need to use a lot of gel. That's it. Oops. Not sure what I'm doing now. Okay. Next thing is that we need to go, just leave it like that. In the groin, we have many vessels, many arteries, veins, yeah, and nerves. It's innervating the whole leg, and that's an important aspect. Okay, let's have a look. What can we see here? Okay. The spina iliaca anterior superior. Everybody knows that place, yeah? And then the symphysis pubis. That is your inguinal line. That's an important one. Because we should not go too low and we should not go too high, but just in that line. Then if you do it immediately, then you can see this is your femoral artery, yeah, and on the right side of it, you see the femoral nerve. Okay, that's very important because if I go a little bit deeper, that's okay. Yeah, I go deeper, you see, now I have two arteries. So make sure that you stay in that line between the spina iliaca anterior superior and your symphysis bone. Yeah, that's important. So we stay here, you see the femoral nerve, it's like a triangle, and I come with my needle from the side, yeah, in line to make sure that I freeze everything. Okay? So you come with your needle from the side here, with your needle, go up, a little bit on this side, so up and lower, and on that side. But don't inject here because you do not want to inject into the artery. You want to avoid arteries at all. Okay, now I go a little bit to the medial side. So it's very clear to see the artery and you see the nerve here. Okay. And this is the vein. Vein is a little bit tiny, and if I push too hard, it disappears. But if you want to insert, you can use, for instance, arterial cannulation for catheters, continuous arterial pressure, or if you want to insert a central catheter instead of the neck, you can use it here as well. Okay? All good? Yeah, all good? Okay. Okay. So that is what needs to be done. It's very important. Now there's a first branch that will branch off. One nerve will branch off here. Which one is that? A very important one. So the first nerve, can you hold this for a moment? Can you hold? Yeah, the first nerve that will come off here will go all the way, just lift it, will come all the way here, like that, and goes to here, just in front of your malleolus. It's a very long one. What is the name of this one? You actually can block it just in front of your tibial bone. Okay, that's a very long one here. It's just a sensory block, and you will not be able to use it as a motor block. It's not. It is not affected. There's no motor branch. Okay, so it's only this one here. And you actually can see it next to a vein, next to a vein here at the top. Look it up in your anatomy books, the saphenous nerve. Okay. Next thing is, okay, you can one second. Femoral nerve is good if you have to do an operations, yeah, in the mid size here. Okay. So any knee surgery, the knee is innervated by the femoral nerve. You need to wait. Okay. So the femoral nerve is something good if you have to do an operations on the knee. Total knee replacement, yeah, it's good that you do the femoral nerve. But it's not enough, because the medial side is innervated by the adductor nerves, whereas the lateral side is innervated by another nerve. Which is rather complicated. Okay? Now, where to find that? You have the spina iliaca anterior superior, spina iliaca anterior superior, 2 fingers above and 2 fingers to the medial side. Okay? And feel. If you feel, then you feel the fascia. You have, obviously, you have the subcutaneous fat, but behind it you have the fascia. Understand? So, 2 fingers above, 2 fingers to the medial side, and you feel the fascia. Just bring a needle in front of that fascia, puncture the fascia, and you will be able to block this nerve. The nerve, the cutaneous nerve, the lateral cutaneous nerve. It's the whole area here on the lateral side. Yeah, you can block with that nerve. It's very difficult to see it with the ultrasound because it's a very tiny one, but you have 3 branches you need to block. The femoral nerve of the knee, yeah, the middle side of the knee, the lateral side, that's a cutaneous nerve, femoral cutaneous nerve. Okay, and then we have a 3rd one, and that is this, yeah, and that is this one. What is this muscle? You see, we are working on the adductors. This is the adductor longus. Adductor longus. And below is the adductor brevis. And even further below, I need to focus on more. Okay. So, adductor longus, adductor brevis, and this is the adductor magnus. Okay? 3 muscles. But in those, between those 2 muscles, we see nerves. So, adductor longus, adductor brevis, and adductor magnus, and we have a nerve here. This is the obturator nerve, the superficial obturator nerve, and this is the distal, the profunda obturator nerve. Understand? So, if you have to do operations on the knee, the medial side, that's where you need to block. Okay, the knee is rather complicated. You understand? So, this is the obturator nerve. You can also use the obturator nerve if you want to do, for instance, prostate surgery. The obturator nerve goes inside to the bladder. You do not want to have bladder perforations, and you can do that as well. Okay? Clean it. Okay, so you can do it from here, so that you can see the nerves very well. Okay, so this is the one we want to block for prostate surgery. Okay. I think you need to have a shower later. Yeah. Okay. Now, oops. That's okay. That's okay. That's okay. Okay, the next one. Yeah. We go here. So I'm now midways of femur, okay? That's the adductor canal. Adductor canal, and in fact, the saphenous nerve is somewhere here. So I told you the first branch off of the femoral nerve is this one here, the saphenous nerve. Yeah, it's going all the way and just in the middle of this bone. Feel your own bone here, the tibial bone, just in the middle. And if you want to freeze it, it's very simple. You go from one end to another end and subcutaneously, and you always have the block ready for this part. Okay, that's for the saphenous nerve. Because if you do the femoral nerve alone, it will not be included. You need to do that in a separate way. So nowadays, for a knee surgery, I see a lot of indications for the obturator nerve. Okay, that is a very popular block nowadays. It's very easy to do. Good. The next one, we have the feet. The feet are innervated by 5 nerves. Okay, one you know already. This is the saphenous nerve. The other one goes with, that's with, in front of the malleolus, so this side. But you can go behind the malleolus. Yeah, that's the tibial one. And the tibial nerve goes for the plantar foot. Understand? There's another branch coming off here, and that's going on this side. So on the lateral side, behind. Yeah, this one here. So we have here the tibial one, the saphenous one, and the sural one. The sural one is here. Sural. Okay. Now, in principle, you can do all of the 3 together, but not the saphenous. The saphenous you have to block separately. But you feel here the Achilles tendon. Okay. You can feel also the arteries. You can feel the arteries. Just above the artery, you can do the injection. And if you go a tiny little bit further, you have both the sural and the tibial one. Tibial and the sural. You understand? That is what can be done. Now, can you go on your belly? Complete. Okay, good. Now, if you want to do, okay, You can do blocks on the back side as well. And that's the saphenous, the sciatic nerve. The sciatic nerve is at the back. Okay? It's very thick. It's like a thumb thick. It's very thick. Okay? And you have to make sure that you know the anatomy. The anatomy, it's okay. It's okay. Yeah, you know the anatomy. You feel a groove in between the biceps and the semimembranosus and semitendinosus. I try to show it to you, okay? Because these are big muscles, it's not always, doesn't always fit the screen, but I'll try. Okay. You see, this is a big muscle, this is the biceps. Okay? Now I'm going to the other side, and this is the semimembranosus and semitendinosus. Okay. In between those two, let's see a structure here. You see that structure? That is the nerve. Just go in the middle between the biceps and the semimembranosus semitendinosus. You actually can feel a groove in here. The only thing what you need to do is go in the middle. Just go in the middle and you will see it. Okay? And you can follow it. You can follow that structure all the way down till the gluteus muscles. With the gluteus muscles, there's too much muscle on top of it, then it becomes very difficult. Sorry. Okay? Those who know the anatomy very well, you still can find the sciatic nerve. It's not always that easy. Yeah? So the better is, don't go too far up. Make sure that you stay here. You see that triangle here? See the triangle? So it's a very thick one. Yeah? So thick as your thumb. Okay? And sometimes it's like a cylinder, sometimes it's like a triangle, like in this particular. If I go down, you just have to follow and use a little bit of movement. Okay? You can see it, huh? Okay, and you go down, down, down. And then all of a sudden it changes. Because then you have the popliteal and the peroneus. See that here? Now I have two structures, popliteal and this is the peroneus. See that? So it's about, well, 6 to 8 centimeters above the crest here. Okay? So the peroneus is going on the lateral side, and you have this little bone here, yeah, the fibula bone, the fibula head, and it just crosses around the fibula head. That's your peroneus. Peroneus is going to innervate just between the two malleoli, where you find the superficial peroneus. Superficial peroneus is for this side of the foot, and just between the first and the second toe, there's a space, and that is the deeper peroneus. Okay? So the superficial is here, whereas this is for the deeper peroneus. Sometimes patients can have pain, chronic pain, because of this particular part. It's called Morton's analgesia, Morton's pain. Sorry. If you give an injection with a local anesthetic and a steroid, usually it disappears. I've done it also for one of my surgeons. It's certainly help. So peroneus, this one, the tibial nerve is this one. Okay, so if you want to give gas, then you need your tibial. If you want to lift it, your peroneus. Good. So that is certainly useful. Make sure that you know this sciatic nerve is a very important, very big one, as you can see here. Okay, and it has a triangular aspect, and then all of a sudden it starts don't go too far below, because then you don't see anything. You need to be here. Okay. Peroneal one, so that's the tiny one that branches off. In fact, that is the most useful regional blocks. There are many more, of course, but this is already very useful if you want to learn the start of regional anesthesia techniques. That's okay. Any questions? Any questions for me? A long day, I guess.
Excuse me, Prof. I want to ask you about the practical. If we do the analgesia for the procedure of cesarean section, we usually use the ERAX implementation, and we sometimes do the block, again a block. The choice is the first one is TAP block, the second one is KR block, and the third one is iliohypogastric and ilioinguinal blocks. From your experience, which one better, most better than?
First of all, I think there's an evolution in techniques. We learned maybe 50 years ago, maybe 70 years ago, I don't know, we learned a certain technique. Okay, we learned to do it without this equipment. Then this equipment came, say, 30 years ago. Okay, we improved it, our success rate improved. Now, all depends on what kind of blocks you want to use and which one you are, well, which you are used to work with. Because it doesn't make sense if block A is going to give the best result if you can't do it. Yeah? You need to decide in your institution, these are the kind of blocks we are introducing, we are teaching, we are practicing. That is the best way forward. There's no really best block in that kind of area. It all depends on how good you can visualize the thing, what is your local anesthetic that you're going to use, and how you, well, manipulate the patient. What you do next. Is it only going to be a block, or do we do something else as well? Is it mainly for the intervention, or is it also for the post-operative pain relief? Are we going to use catheters, for instance? Understand? So it's very important to have that global idea. What exactly are we doing in this department? What kind of blocks are we using? And it doesn't make sense to try to know all the blocks if you still have to start with the essential ones. Try to find and define, these are the blocks we are doing, and we are going to concentrate and make ourselves as acquainted as possible, and make sure that we do the technique in the best possible.
Okay, second question, Prof. If recently we always use K-guided for the regional blocks, how is about the use of the nerve stimulator?
The nerve stimulator. Well, look, I remember the time that we were using nerve stimulators. But now that we can visualize it, it's even better. Because with the nerve stimulator, you're never sure whether I was too deep, which is not good either. You do not need to insert a needle into the nerve itself. That is blowing up the nerve, and that may cause pain problems later. Yeah? So the nerve stimulator certainly will help in certain circumstances when I'm not 100% sure what I see, but it's not so frequently used as it was in the past.
What's about to combine it or
You can combine it. I've done it using combinations.
for the safety? Recently, if you compare with the USB-guided alone and compare with the USB-guided with nerve simulator, it's
I see the best results with the ultrasound. And those who are very proficient in using ultrasound and doing the blocks using ultrasound don't need anymore the nerve stimulator. If you are unsure, why don't you use it? Ask a colleague to help you.
Thank you so much, Prof. Mungkin maybe for the last question, if we do the regional blocks, what is the specific target we see at the ultrasound, the nerve, or we specific target we search the nerve seat or around the nerve?
Don't inject into the nerve. If you blow up the nerve, the whole structure will disappear and you can have long-lasting neuralgia pains. And so don't do that. Always around the nerve, because a local anesthetic will infiltrate the nerve. That is what we want to do. We do not want to inject it. It needs to be infiltrated. Yeah, around the nerve. But make sure around the nerve are also the arteries, that you don't inject into an artery. That's important. Yeah, not in a vein, because then you have toxic reaction. You understand? There's lots of common sense, but you need to visualize it and use these structured anatomy images to learn it first, so that you really understand this is there and this is there and this is what I can expect, and side effects and complications, and that you know how to handle your complications. Yeah? If the intralipid 20% needs to be there where you're doing the blocks, because it's always possible to inject a local anesthetic into a vein, and then you have toxic reaction. It can happen already with small amounts of small volumes. So be prepared. So I think the area where you do the block, where you have your ultrasound machine, always make sure that you have your resuscitation equipment, inclusive the intralipid 20%.
Okay, thank you so much, Prof, for the insight from the audience.
You can mix local anesthetics like with any drug that we do in anesthesia. General anesthesia is usually a mix of drugs. Regional anesthesia, you can also mix it with combinations, with opioids, with DEXA, you name it. Dextrose is usually to visualize it better. Dextrose, you add that on, that's just to visualize better on the screen. So it has no further function. The dextrose. Okay? But if you want to have a long-lasting block, the local anesthetic plus an opioid will last longer than just a local anesthetic. That's the disadvantages. If you do a block, and it's not a continuous block, it's not with a catheter, it will last usually till after midnight. You understand? And then the patient has a lot of pain and we are no longer there to help. So for that reason, it's better to combine it with an opioid. But make sure for your institution that you have this particular scheme of, well, combination that you want to use, so that there is no overdose and that you know exactly what to do.
Okay, any question again from the online audience, maybe? Oh, Janice.
The first parameter is always look at the patient and his reaction. Okay? If it is intravascular, it will cause pain. Patient will not like it. Okay? That's one thing. The second thing is, if it is intravascular, you will see the patient. He will not feel very well. He may not say anything, but he will feel terrible. Yeah? He may not say, but that's the reason we have to talk to the patient. Say, how's it going? So just a little bit of conversation to find out. If he tells you, now I feel a little bit odd, a little bit odd in the head or whatever. You understand? That is well, that is important. I want to see the face of the patient when I'm doing any injection. I want to talk to my patient because he will tell me if something is not right. Lightheadedness, but he will tell me. He said, oh, I have a hot feeling. Then be careful. Stop the injection. Check, aspirate. Yeah, and check what you are doing. Aspiration is a very important one. Never do full injections. Always do it fractionated. I told you at the beginning, test dose, every dose in every epidural analgesia should be a test dose. No more than that. If you do it that way, you'll always be on the safe side. So if you do an injection, for instance, for the sciatic nerve block, that is a lot of local anesthetic, 20 cc, maybe 25 milliliters, but don't put them in one injection. Just slowly, like a couple of cc's and wait. See the reaction. Another 2-3 mils, and you just build it up.
Okay, thank you, Prof. Any question again from the online audience? Okay, if there's no question, we close the session, Prof. Okay.
Thank you very much for your attention and for coming this morning.
Thank you so much, Prof. On behalf of the organizing committee, I would like to express our sincere gratitude to Prof. André van Zundert for the excellent lectures and workshop, as well as to our participants for the active participation. We hope this session has been beneficial and enriching for our daily clinical practice. Finally, I would like to hand over the session back to the master of ceremony. Thank you very much.
Thank you very much. Professor Made told me this morning it was my 22nd time already. Of course. You see my picture over there? Yeah. Thank you very much for coming here. It is also good for myself if I come here and I see all the interest that you have in my lectures and my topics, and if you want to read more about it, well, go to the internet, my name, and you will find it, I'm absolutely sure. But it's already a lot, 550 or more publications, so it's hard work, and 8 books and 85 book chapters, so it's a lot of work to be done if you want to read everything about it. But the good thing is, it should be a take-home lessons for you. It should be a take-home lessons that I want to inspire you. I want you to see there's a lot to be done in anesthesia, regional anesthesia, general anesthesia, and it needs to get your attention. You need to enjoy it. You need to enjoy what you are doing. And that's what I'm doing my whole life. I've been enjoying all the things that I'm doing. And the benefits is that I can come here and that I can meet you. And that is so wonderful. So thank you for that.